Good morning. It is 8:30 and we are going to begin the webinar now.
Okay, good morning all. It's wonderful to see so many people here today on a cold Sunday morning. Welcome to the 7th Annual Patient Education Day from the Georgetown Multiple Sclerosis and Neuroimmunology Center. It is a real pleasure for me to do the introduction. I'm going to be sharing my slides in just a second, so let me go ahead and do that. And Bethany, can you confirm that you guys can see the screen?
We can see it, but it is not in presenter view.
Yeah, that's okay. I'm doing that intentionally.
Thank you.
Okay. So at the top is, you can see our introductory. At the bottom is the site that you currently are on. All the slides that I'm going to show you are on here. So you can see the agenda at the bottom right, the faculty bios, the sponsors, and the resources. Everything that I'm going to show you on the subsequent slides are available on the website that you're currently at. So if we go to the sponsors, and again, thank you so much to our sponsors who, without whom we would not be able to put this on. Specific thanks to our platinum sponsors, so Biogen, Bristol Myers Squibb, Genentech, and Novartis. And when you go into the site and you click on those sponsors, you will be able to get into the sites. So each one of those will go right into their sites. That's great. Thank you to our gold sponsor, Janssen, from J&J. Our silver sponsors, Alexion and Horizon. And then our partners, the National African American MS Registry, and of course, the National MS Society. I would encourage you during the break, you can go into these sites and look at a lot of resources that are available there. And please, there's a lot of great information that you'll be able to access, not only now, but in the future. Other resources that are, again, available, when you're on the site, if you look to the far right where it says resources, you can find our previous recordings from 2020 and 2021. Simply click on the link and you'll be able to watch the whole 4 hours of both of them. There's also a great, oops, sorry about that. There are also some great online resources that you can use this to jump into. So the National MS Society, again, is a nonprofit organization that helps advancement of research and treatment of patients with MS. There's also the Sumaria Foundation for Neuromyelitis Optica, or NMO, and Dr. Osborne will be talking more about that. But that's a nonprofit organization supporting patients with NMO, which is an MS-like disease, but is distinctly different. There's also the Guthrie Jackson Foundation, another nonprofit organization supporting research in NMO. This year we have Eat MS, which is a nonprofit organization that was created to be a reliable food supplier for every MS patient and caregiver. And then there's a great link to We Are Ill, and we'll have a speaker later. This is a nonprofit patient advocacy organization with the mission to redefine what sick looks like for Black women living with MS. And then the Adaptive Sports and Fitness Program has a link. They too will be giving a presentation later to help maximize participation for individuals with disabilities in recreational and competitive sports. Again, you will see that. And then the great downloadable resources, there's the Eat MS overview and the Eat MS Living with MS. So again, all those resources on the site, if you go to the top right, you'll be able to click to those. Our agenda is pretty packed today. We have wonderful speakers, including most of these folks. I think all of you know Dr. Amjad, Dr. Osborne, David Pisful, Elizabeth Parker, Dr. Breo, Kim Foster, Dr. Manrique, Victoria Reese, And so there's a couple more, I think, that I lost there. Yeah. And then we'll have a Q&A at the, okay, so definitely put your questions into the chat. We will get to as many as we can, and definitely, stay engaged through all of it. Again, use the Q&A box to ask any questions. We're going to get to as many as we can at the end of the program. Again, thank you so much for joining us this morning. We greatly appreciate it. And I'm going to hand the baton off to Bethany at this point.
Thank you so much, Dr. Tornatore. So we will dive right in. And our first lecture is on sexual dysfunction by Dr. Faria Amjad. Dr. Amjad is the director of the Spasticity Clinic and also the director of clinical trials involving autoimmune disorders affecting the nervous system. She currently sees patients at MedStar Georgetown University Hospital and our only satellite clinic. This topic has been requested multiple times in our evaluation forms, so we're very excited to hear more today. And as Dr. Tornatore mentioned, feel free to type any questions that you have in the Q&A box, and we'll have time at the end of the morning for question and answers. So go ahead, Dr. Amjad. Thank you.
Thank you, Bethany and Dr. Tornatore, and thank you everyone for joining this morning, cold, early Sunday morning. I'm going to share my screen first. Okay, so put this in presentation view. Okay, slideshow. So as Bethany was saying, sexual dysfunction is one of those things that has been brought up by you guys after each patient education day. And quite frankly, we sometimes don't talk about it enough in our own personal clinic. So I think this is a great time to discuss it together. So MS, give me just one second. MS, as we know, is the leading cause of progressive neurological disability in young adults, and that comes about for many reasons, right? MS can affect you cognitively, it can affect you physically. So musculoskeletal deficits in the form of spasticity or muscle weakness and gait dysfunction. Pain, this can be neuropathic pain, which usually presents with painful burning, which we refer to as dysesthesias. It can even be annoying pins and needles pain, or just frank numbness. Spasticity can also present with pain in the form of painful muscle spasms and cramping, and obviously can affect someone's ability to function and move. Cognitive impairments, typically in the form of inattention and sometimes memory disorders. Fatigue, something people are very familiar with who have MS. And then depression and anxiety. And then the last thing would be autonomic dysfunction. So this would include deficits which affect someone's bowel and bladder, but sexual dysfunction also comes under the umbrella of autonomic dysfunction. Now, all of these things put together, and again, this is not an exhaustive list of deficits, can eventually lead to sexual dysfunction. But let's talk about the prevalence of sexual dysfunction in MS. Male patients with MS, it's thought that male patients with MS have a prevalence of 50 to 90%. Now compare this to the general population, where it's 20 to 30%, so 2 to 3 times higher in men living with MS experience some level of sexual dysfunction. When it comes to women, we think that it's around 40 to 80% of women who have MS may experience some form of sexual dysfunction. Compare that to the general population, where it's estimated to be around 40 to 45%. Now, sexual dysfunction can arise at any time during the disease course. It doesn't have to happen later on in the disease course. It doesn't necessarily have to be correlated with an increased level of disability and examination. It can occur very early. So for instance, 1/3 of newly diagnosed women were affected with sexual dysfunction despite no other major neurological impairment. So there's something called the EDSS. It's a scale that goes from 1 to 10. And the higher your score, the higher the level of disability. So sexual dysfunction may not be captured very well on that scale. So someone with a very low score, let's say 1 or 2, may still have issues with sexuality or their sexual function. So before we get into sexual dysfunction, we need to understand the normal human sexual response cycle. So for men, for men and women, it really starts off with libido, and that's defined as a desire for sex, which then leads to arousal, an erection, ejaculation, which may or may not lead to an orgasm, and then detumescence. For women, starts off with libido, arousal, increased vaginal blood flow and lubrication, which then leads to clitoral engorgement with blood, and then may or may not lead to orgasm and then resolution. So this is the normal human sexual response cycle. Anything in sexual dysfunction can occur at any of these stages, okay? So sexual dysfunction in MS is separated into 3 separate categories: primary, secondary, and tertiary, and we're going to define all 3. So primary causes of sexual dysfunction in MS are secondary to the actual lesions. So remember that whenever we review MRIs with patients, we show you those white spots, and those white spots are areas of inflammation, prior inflammation. There's scar tissue, okay? They're not supposed to be there. And because they're there, it interrupts the normal neurological pathways that first originate in the brain or the spinal cord and then emanate out to the peripheral nerves and to the rest of the muscles and the rest of the organs. So anything that impairs those pathways can lead to sexual dysfunction. So it's the physiological result or the physiological consequence of those lesions. Okay, so for examples of primary causes of sexual dysfunction would be impaired genital sensation. So people who have numbness or pain in the genitourinary area, decreased vaginal lubrication for women, sexual pain disorders, and really this is specific for women. Vaginismus and dyspareunia are examples. Vaginismus is basically when the vagina spasms up and whenever penetration is attempted. And then dyspareunia is actual painful sexual intercourse. And then orgasmic dysfunctions or failures of arousal. So for men, this could be delayed, absent, or premature ejaculation. For women, it could be a failure of clitoral engorgement, which is really necessary for an orgasm to occur. Okay. We'll talk about secondary causes of sexual dysfunction. So this results from an indirect result of those lesions. So basically the symptoms that we manifest secondary to MS lesions. So for instance, fatigue, and fatigue actually affects 75% of patients with MS. So if someone is very tired, they may not have the interest for sex, or they may just be very tired for sex, especially at the end of the day. Cognition, so cognitive dysfunction, so reduced attention and concentration can also affect someone's sexuality. I mentioned this earlier, but sensory deficits, so pain or numbness, tingling, burning, sensation can obviously lead to sexual dysfunction. Dysesthesia, which again is burning, and the allodynia is a painful response to something that should not be painful. So even normal touch can feel painful for that person. That's allodynia. Muscle weakness, especially pelvic floor muscle weakness or lower extremity weakness. Spasticity, I see this a lot in my clinic. This is essentially increased tone or increased stiffness of the muscles, particularly when it comes to the adductor or adductor muscles. These are the thigh muscles. So if the thigh muscles are too tight, the legs stay closed together. You cannot open your legs for sex. And then obviously spasms and cramping can also affect sexual function. Bladder dysfunction. So if you have an overactive bladder or you have bladder incontinence, obviously that's not very conducive for sex. Same thing goes for bowel dysfunction, although we see bladder dysfunction a heck of a lot more. Incoordination, reduced mobility, and then medications. So a lot of the medications that we use to control a person's symptoms can have their own sexual side effects. Tertiary causes of sexual dysfunction. So this is where we have to consider psychological, emotional, social, and cultural aspects of our experience, which then go on to shape our perception and experience of sexuality and sex. And again, this can affect any person, whether they have MS or not, but changes in your body image, how you feel about yourself, how you look at yourself in the mirror, feelings of anger, feeling less sexually attractive, a diminished level of confidence, worries about satisfying our partner sexually, difficulty communicating with that partner, feelings of guilt around sex, feelings of dependency. And then lastly, depression, which we will talk about at the very end, obviously can affect our sexual arousal and our desire for sex and our experience of sex. So just a couple of facts, the risk for depression in patients with MS, a lifetime risk is up to 54%. compare this to other chronic medical conditions where it's estimated to be around 13%. And for the general population, it's around 10%. So we have significantly higher rates of depression in patients living with MS. Let's talk about men. So I'm going to just split up the talk here now. We're going to start off with men, and then we're going to talk about women. But for men, common presentations of sexual dysfunction or erectile dysfunction, that's by far the greatest, 50 to 75%. And again, there is no association here between the age and erectile dysfunction. So typically erectile dysfunction does tend to occur more as men get older, but with MS, that's not necessarily the case. It could even affect young men because of, remember, those brain and spinal cord lesions. Ejaculatory dysfunction is estimated to be around 50%. A reduced libido or reduced desire for sex is around 39%, and orgasmia, 37%. And again, no significant relationship between the duration of the disease and the prevalence of sexual dysfunction. So it can occur early on. I'm going to focus quite a bit of time here about erectile dysfunction. This is something that men experience the most when it comes to sexual dysfunction. And so when we talk about erectile dysfunction, a couple of things to consider. So a question that the healthcare providers may ask is the onset and the duration of these erectile problems. They may even ask the quality of erections. Is it a matter of achieving an erection or maintaining an erection, or is it both? Because it can be both. And then the context of erection, does it occur only when you're with your sexual partner? Does it also occur when you are masturbating? And then does it also affect your morning erections, which may indicate maybe a primary cause, so secondary to those lesions, or maybe a hormonal cause or a neuroendocrine cause for the erectile dysfunction. So the management of erectile dysfunction, the first line management is typically involving phosphodiesterase 5 inhibitors. These are oral medications. People may recognize them as, so Viagra is sildenafil, and then Cialis is tadalafil. Both are the most commonly used phosphodiesterase inhibitors in the United States. And these medications are used to promote and prolong an erection. However, sexual stimulation is still required for these medications to have an effect. So they are therefore taken prior to intimacy or prior to intercourse. Okay, Cialis, tadalafil, actually has a longer duration of effect, and therefore it can be taken daily if someone is anticipating having sex at least twice a week. Okay, some of the adverse side effects associated with these medications include headache, flushing, nasal congestion, and sometimes even blurry vision. They are contraindicated, especially in patients who may have had a history of cardiac infarction or heart attack, and they may be on nitrates for angina. So that is a contraindication with these medications. Okay. Now, if there's an inadequate response to these first-line medications, and actually 25% of patients may not experience any response at all, there might be some reasons for this. Either maybe an insufficient dose is being used, maybe the timing between when the medication is taken and the sexual intercourse, maybe there's an issue there. Maybe there's inadequate sexual stimulation or foreplay to facilitate arousal. And then other causes of sexual dysfunction may also need to be considered, such as hypogonadism. Essentially, that means that there is either a decreased production or an absent production of sexual hormones, specifically testosterone. Okay. Other ways to manage erectile dysfunction in men: vacuum constriction devices. These, and I put a picture here on the right, that's a vacuum. And obviously it's placed around the penis. There's a vacuum that is created that pumps the air out and allows the penis to become erect. These can actually be used in conjunction with the phosphodiesterase inhibitors. Now, one limitation, obviously, sometimes MS can affect a person's upper extremity function, so their arms or their hands, and you do need your hands and your arms to place this. And then the other issue might be with this device specifically is that there might be issues with ejaculation. Now, the other thing to remember is that actually men can also obtain vibrators, which also help with sexual stimulation and therefore erection. Okay, and there's a picture of that right there. Another way to manage erectile dysfunction in men is actual injections of something called prostaglandins into the penis itself. Okay, and the way these medications work is that they allow for smooth muscle to relax, for the penis to become engorged with blood, and for erection to occur. Okay. Obviously, it's not necessarily a very attractive choice because these are injections into the penis. And then some of the side effects would be groin and penile pain, painful erection, also known as priapism. And then with repeated injections, you can actually form penile fibrosis or scarring of the penis. Okay. This is a penile prosthesis. This is a surgically implanted device that needs to be turned on when sexual intercourse is about to occur. There's a picture of that right there. Obviously, there are some issues with this. The device can fail. People can have infection, and therefore you may need revision surgery for this. Okay. So very quickly, other causes of erectile dysfunction that should be considered outside of causes related to MS or neurological issues, vascular risk factors, which is huge, typically occurs as men get older. So high blood pressure, hypertension, hyperlipidemia, diabetes, smoking, being overweight, or a family history of vascular disease can lead to sexual dysfunction in the form of erectile dysfunction. Urological issues, which might lead to erectile dysfunction, painful curvature or deviation of the erection, and obstructive urinary symptoms, specifically an enlarged prostate, can actually lead to erectile dysfunction. So endocrine or hormonal issues, which might lead to erectile dysfunction, or reduced libido, secondary to hormonal issues, weak morning erections, and then hypogonadism. Again, this is a decrease in the formation or an absent formation of testosterone. Some other manifestations of this could be reduced body hair, gynecomastia, which is essentially breast formation in men, testicular atrophy, the testes actually look smaller, and then failure to respond to those first-line phosphodiesterase inhibitors, so Viagra or Cialis. A way to test for this would be to test the serum concentration of testosterone. Typically in the mornings, 8 to 10 a.m. would be the best time. And if it's low, then other hormones can be checked for, such as TSH, FH, or LH, and prolactin. And again, this has to be done in conjunction with an endocrinologist. Okay. Now let's shift gears to women. So common presentation of sexual dysfunction in women: reduced libido. A lot of women, 31 to 64% of women with MS may have this. Problems with arousal, and that leads to decreased vaginal lubrication. 60% of women with MS have reported reduced genital sensitivity, and therefore may have either an absent orgasm, a delayed orgasm, or a very weak orgasm. Okay. Failure to orgasm altogether, about a third to 40% of patients might have this. And then sexual pain, so dyspareunia and vaginismus. Again, difficulty with basically pain with intercourse, or the vagina itself contracts or spasm, which can itself be painful. Okay, so how do we manage this? Now, interestingly, Viagra was looked at for women's sexual dysfunction, and unfortunately, it didn't really show an improvement in orgasm quality and therefore quality of life. There was a small benefit with vaginal lubrication with Viagra, but again, it's something that is not, it's not indicated for women's sexual dysfunction. Dyspareunia, again, this is pain with sexual intercourse. Some ways to get around that would be to use anesthetic gels, water-soluble lubricating gels to make sex easier. And then topical estrogen. So topical estrogen, typically we see urologists or gynecologists prescribe this for women who are menopausal. And the reason for this is that as women get older, they can develop vulvovaginal atrophy. So what that basically means is that the walls of the vagina either thin, they begin to dry out, and this is secondary to inflammation. That can make sex very painful. Okay. The other reason to use topical estrogen is that it can actually improve clitoral sensitivity and therefore the likelihood of orgasm. And again, they can reduce the pain that occurs with sexual intercourse. And interestingly, one other thing that I've noticed in clinic that urologists will sometimes do is that they will use it for bladder dysfunction, so decrease bladder urgency, frequency, and even sometimes to prevent UTIs. Okay. Lastly, for decreased genital sensation or stimulation, again, there's a decrease in the sensitivity of the vagina and the clitoris, and therefore it might lead to orgasmic dysfunction. One way to get around that would be to use a vibrator, specifically a vibrator that has a high frequency, okay? And there's a picture of that. So other things that might lead to sexual dysfunction in women is bladder and bowel issues, specifically bladder urgency, bowel urgency, and then sometimes urge incontinence. So anticholinergics, these would include things like oxybutynin. Vesicare is oftentimes used for bladder dysfunction. Unfortunately, these medications are anticholinergic, and that can lead to vaginal dryness. Again, there are ways to get around that, including lubricating gels. Other things that might help with bladder dysfunction is tibial nerve stimulation. Okay. Botulinum toxin can actually be injected directly into the bladder wall to relax the bladder wall and therefore decrease urgency incontinence. Emptying the bladder before intercourse can be helpful. Some women require a catheter for bladder dysfunction. Now, there are two types of catheter, the suprapubic catheter, which comes out of the abdominal wall, versus a Foley or a urethral indwelling catheter. Obviously, that would make sexual dysfunction much more difficult. So maybe to get around that would be to prefer a suprapubic catheter. And then fecal incontinence. One way to get around that would be to use a microenema prior to sexual intercourse or an anal plug during sexual intercourse. Management of pain. So again, we're going to focus on more neuropathic pain here in the form of burning or dysesthesia and allodynia, which is basically a painful response to something that should not be painful. These are just some examples of the medications we might use for neuropathic issues. So anti-epileptic medications, things like carbamazepine, lamotrigine, also known as Lamictal, and gabapentin. Okay, antidepressants, so the tricyclic antidepressants, this includes things like amitriptyline and duloxetine, and then local anesthetics and non-steroidal analgesics. Just a quick thing, and we will discuss this at the very end, but unfortunately, these medications themselves may have their own sexual side effects. Okay. Now, mood-related factors, and we know that depression and mood disorders tend to be multifactorial. Could it be secondary to the lesions in the brain, immune dysregulation from MS, neuroendocrine and hormonal issues, and then family or personal history of depression? So it's a very complicated thing. Now, again, depression is very prevalent in the MS population. It affects more than half of patients over the age of 60. Can manifest with decreased libido or a lack of interest in sex. Now, typically the first line type of medications that we use for depression are the SSRIs. Unfortunately, the SSRIs are known to lead to sexual dysfunction, and this can be a decreased libido, reduced or delayed or ejaculation in men, and therefore orgasm. They can contribute to genital numbness, and they can also lead to weight gain. So again, that idea of body image. There are some alternatives to the SSRIs which may not carry the same risk for sexual dysfunction. Bupropion being probably the most well-known. Bupropion is a norepinephrine and dopamine reuptake inhibitor. Another medication which is not like bupropion, but that's trazodone and mirtazapine. So these three tend not to have the same sexual side effects that the SSRIs might have, and therefore can actually be added on to the SSRIs to decrease their sexual side effects. This is a list of medications that we sometimes use often in clinic. So for instance, I use a lot of baclofen. Baclofen is used for spasticity. Unfortunately, baclofen can lead to erectile dysfunction. Okay, so maybe an alternative to that would be some of the benzodiazepines. Here, this would include things like Valium or clonazepam. Clonidine is not a benzodiazepine, but can be used for spasticity and does not tend to have the same sexual side effects as baclofen. Some other very common medications that we use, so for instance, duloxetine or Cymbalta can be used for neuropathic pain and also for depression. Fortunately, it can also have the side effect of decreased libido, erectile dysfunction, impaired ejaculation, and lack of orgasm. So maybe alternatives to that for, let's say, neuropathic pain or even for mood stabilization would be carbamazepine, oxcarbazepine, and gabapentin. Okay. Lastly, I'm going to point out the anticholinergics at the very bottom. These are medications that we typically use for bladder dysfunction, and this would include things like oxybutynin, Vesicare. Those types of medications can lead to vaginal dryness. Okay, and again, vaginal dryness can lead to lack of sexual stimulation and therefore orgasm. So an alternative to that, which is relatively newer, is something called Myrbetriq or Mirbegaron, which doesn't have the same sexual side effects. Okay. Now, so let's move away from medications and other like surgical interventions. Sex therapy. So talking to a therapist who specializes in sexual dysfunction might be very helpful. And these therapists will also focus on things like communication training. So up to 71% of patients with MS and sexual dysfunction report marital problems. And actually, with some counseling and group therapy or couples therapy, which then leads to positive support, can actually really improve a couple's sex life. They can also teach you about positional ways to have sex, different positions, sexual devices or aids. They can also talk about other areas that can lead to sexual stimulation outside of the genitals, and this is referred to as body mapping. Okay. Psychotherapy, cognitive behavioral therapy, and essentially cognitive behavioral therapy, as in a nutshell, is trying to replace negative thoughts with more positive thoughts. So if someone has, for instance, negative thoughts regarding their own body image, you try to actively, awarely replace those negative thoughts with more positive thoughts. And if you do this enough, it sort of becomes entrained. Okay. Barriers for discussion about sexual dysfunction. So I think this really applies to both healthcare providers and patients. Up to 63% of patients with MS have never mentioned their sexual dysfunction to their healthcare providers, and therefore it's under-recognized and under-treated. Obviously, if you don't talk about it, we don't know, we can't counsel you, we can't manage you. And I'll be honest, there is a sense of discomfort. From a patient's perspective, it's something that is very private. They may not want to talk about it with their healthcare provider. From a healthcare provider perspective, it's really because we may not have the knowledge to appropriately guide you. And also, again, there's a sense of discomfort around this issue. In clinic, we are constrained by time, and the focus sometimes is on other neurological deficits which may occur from MS, which takes priority. And therefore, and then one last thing in terms of the barriers, sometimes patients come in with their friends and family, and again, this might not be something that they're comfortable discussing in front of them. How do we overcome these barriers? One thing we may want to do is maybe ask the patient, hey, do you want to talk alone about this if they are coming in with someone? And if they're alone, maybe take that time to discuss it, sort of create a safe and confidential environment. Ask very open-ended question. I know when I talk about sexual dysfunction, I tend to start off with issues regarding the bowel and bladder, again, the same area. So it's a nice segue to talk about sex. And again, sort of framing the discussion around sexual dysfunction as a holistic approach. And when we do our neurological review of systems, this should be included in that review of systems, okay? There are questionnaires that are geared toward trying to figure out whether someone has sexual dysfunction. And so this can be done in private. The patient can fill it out maybe at home or in the waiting room and then hand it to their provider to look over. And then it starts a discussion. And multidisciplinary approach, very, very important, right? Neurologists are not urologists. We're not endocrinologists. So to actually refer people to have a team-based approach with different subspecialists involved, I think is probably the best approach. Okay, these are some examples of some of the questionnaires that might be used. Some questionnaires can be given both to men and women. Some are designed for one particular sex. Okay, and again, this is not an exhaustive list, and by no means are these questionnaires standardized. Okay. And I think that's it. Thank you.
Thank you, Dr. Amjad. very much. That was wonderful. Our next speaker is Dr. Benjamin Osborne, who will be talking to us about neuromyelitis optica spectrum disorder. Dr. Osborne is the director of the Neuromyelitis Optica and Neuro-Ophthalmology Clinics. He also directs the Multiple Sclerosis Fellowship Program. He sees patients at Georgetown University Hospital, MedStar Washington Hospital Center, and our satellite offices in Chevy Chase and Silver Spring. Thanks, Dr. Osborne. Go ahead.
Thank you. Dr. Amjad, could you just stop sharing your screen, then I'll share my slides next. Thank you, Dr. Amjad. Also, that was a great talk. All right. All right, good morning, everybody. Whoops, I'm on the wrong slide there. Let me get to the beginning, sorry. Thought I was on the first slide there. All right, there we go. So good morning, and again, welcome to our 7th annual Patient Education Day. I'm going to be discussing NMOSD. I've done a talk like this before. I'm framing this one as FAQ, so frequently asked questions. So my goal is to hopefully answer all questions that you might have about NMOSD, including what is NMOSD, where is it, why is it there, and when. So what is NMOSD? So it's an autoimmune disease affecting the central nervous system. And the central nervous system, as you're sure most of you are aware, is the optic nerves connecting our eyes to the brain itself, and then the spinal cord, which connects our brain to our arms, our legs, our bladder. And it causes symptoms and disability through relapses. And if you're reading this, you might be thinking, wow, that sounds a lot like MS. And that's because you could use this definition also for MS, and you'd probably be right. So there's a lot of similarity between NMO and MS, and that's why we're including it in the MS Patient Education Day. So a little bit more detail. So NMOSD, what does it even stand for? It's neuromyelitis optica spectrum disorder, or NMO for short. It used to be considered a severe variant of MS. When I was a resident, that was the teaching. They used to think that in East Asia, they had the severe variant of MS called optical spinal variant for many years. And then about a decade ago, they studied these patients who they thought had optical spinal variant of MS, and they did further testing. And it turns out most of these patients actually have NMOSD. It also used to be called Devick's disease or Devick's disease. That's because it's named after the first physician who published about this disorder. And this was a long time ago. So this is not necessarily a new disease. This was first described in 1894. Devick and his student reported findings of a patient who had complications from transverse myelitis and optic neuritis. And when they did the autopsy, they actually found the brain looked normal. And there was severe demyelination and necrosis in the spine and the optic nerves. And the spine, when there's inflammation, demyelination, necrosis there, that's what we call transverse myelitis. And when the optic nerves are involved, that's optic neuritis. And what was really important is that they thought the brain was normal. And so for many years, really for decades, if not 100 years, the teaching was Devick's disease was optic neuritis, frequently bilateral, transverse myelitis with a normal brain. So when we had MRI scans come along and we started doing MRI scans, by definition, we said that if somebody's MRI, the brain was abnormal, they couldn't have Devick's disease because that's not part of Devick's. We later learned that was wrong, but that was the teaching for many, many years. So where is NMOSD? So obviously it's in the optic nerves in the spinal cord. Devick recognized that back in the 19th century. But we now know it's also in other parts of the brain. So as I mentioned, the brain isn't normal and there can be other parts involved. So there's different parts of the brain. I'm not going to go into too much detail about this, but I'll show you some highlights of what I'm talking about. But there's the brain stem, that's the bottom part of the brain that connects the brain to the spinal cord, has lots of important real estate in the brain stem. The area postrema is a very tiny part of the brain that's actually can cause significant symptoms that are really only seen in NMO. We don't see inflammation in the area postrema with MS or many other neurologic diseases, and then diencephalon. So I'm going to focus a lot on the optic nerve. That's just my bias. My training is as an ophthalmologist. So I'm going to just focus on that, but I'll talk on other aspects of NMO. But optic neuritis, again, there's sudden vision loss over hours to days. Usually there's pain and eye movements. So there's some discomfort in the eye. And in NMOSD, there are several features that are characteristic of the vision loss. It's usually quite severe, although there could be mild cases. More often than not, this vision loss is quite severe. So the patients can't even see the big E on the eye chart. So the big E is 2400, 20/20 being normal visual acuity. When you go to the eye doctor's office and they're checking to see how low you can read on the eye chart. So the bottom line would be 20/20, whereas the top, the big E is 2400. Many patients sometimes can't even see that. They may have recurrent attacks. So it might be their second, third, or fourth case of optic neuritis. And unfortunately, the vision loss might be permanent. There might be permanent vision loss, even with aggressive treatments such as steroids. So let's go through a case. I think cases sometimes are very helpful for putting this in perspective. So this is hypothetical. This is based on a real patient, but obviously the name's been changed. So Anne's a 42-year-old female. 2 days earlier, while she was at work, she noticed sudden onset of blurry vision in her left eye. When she looked up or when she looked to her left, she noticed there was moderate pain. And she had no prior issues with her vision, except she was nearsighted, so she had to wear glasses, but when she wore her glasses, usually her vision was fine. So when she came to see me, this is what her eye exam showed. So her right eye, the abbreviation OD means right eye, that was normal. She was seeing 20/20, but she could only count my fingers. If I was holding my fingers up, she could correctly count them, but she couldn't see the big E on the eye chart in the left eye. When we did visual field testing, she had a large blind spot in the left eye, or scotoma is the medical term for that. I tested color vision. Her color vision was normal in the right eye, but she had absence of color vision in the left eye, which is very common in optic neuritis. And then when I checked her pupils, that's when the doctor shines those super bright lights in your eyes during the eye exam. We saw that there were signs suggesting that she had optic nerve problem. That's called an afferent pupillary defect, and I'll show you an example of that. The rest of her neurologic exam was completely normal. So this is that visual field test. So this is from the patient's perspective, how they see the world. It's a computerized test. It's kind of boring. You kind of put your head on the chin rest, and then every time a light flashes, you're supposed to click on the button. And if you see the light flash, then the computer marks down that you saw it. And so you can see here in the right eye, this is normal. She didn't have any blind spots that were picked up by the computer. She was seeing all the clicks, all the lights flashing in her right eye. But in the left eye, you can see these blacked out areas where her vision was missing. So there's more than just checking visual acuity, you know, how low can you read on the eye chart? There's also visual field testing, which is very important for figuring out what kind of vision you have. And then I mentioned we like to, as neurologists, shine bright lights in your eyes. And so when I shined the light in Anne's right eye, both of her pupils, the black hole in the middle of the eye, that shrank, that constricted, which is normal. But then when I swing it to the left eye, the affected eye, you can see the pupils dilate, and that's not normal. And this is very helpful for me as the neurologist because it tells me that the problem is the optic nerve. You know, somebody comes in with vision loss, we have to figure out, is it a cataract, is it glaucoma, is it a retina problem? And when I see this finding on the eye exam, it hones me and I know it's an optic nerve problem. So then I dilate her eyes and I look in the back of the eye and her optic nerve looks normal. And I just highlight, this is just an example of a dilated eye exam. That's the actual optic nerve. And it's kind of cool that we get to actually look at this as physicians because that's actually the most anterior aspect of the brain. So when I'm looking in the back of your eye and you're kind of annoyed because it's a bright light, just keep in mind that the doctor's actually looking at the very front of your brain when we look in the back of your eye. And interestingly enough, most of the time in optic neuritis, the optic nerve looks normal when we dilate the eyes and we look in the back of the eye. It doesn't look like there's damage or inflammation there that we see early on. So how do we look at the rest of the optic nerve? This is only the very front of the optic nerve. So anybody in the audience have an idea? I know you can't answer out loud, but I'm sure you're all thinking, how is the doctor going to look at the rest of my optic nerve? You're probably thinking maybe he's going to get an MRI, and you're right. So we actually get a special type of MRI. This is called an MRI of the orbits. So you can do an MRI of the brain, but you can also do an MRI of the orbits, and it actually gives us very thin cuts that highlight the optic nerve. Now, this is kind of flipped when we look at the MRI. So here, right is left, left is right. So the right eye is on the left side of the screen, and the left eye is on the right side of the screen. And what you can see here is the contrast is leaking into the optic nerve and the left optic nerve. Almost the entire course of the optic nerve is showing enhancement. So that tells us there's inflammation there, confirming. This is just another view of the optic nerve. This is called a coronal view. That's just confirming that there's optic neuritis. And when we actually did look at the rest of Anne's brain, I'm not going to show it to you, the rest of the MRI was normal. So we didn't see any other evidence suggesting that she had MS, which is a common cause of optic neuritis. And so we're always trying to figure out, well, what's causing the optic neuritis? Is it MS? That's probably one of the most common causes. Is it idiopathic, where we don't know what caused it? There's just no associated disease. Or is it one of these rare diseases like NMO? And the length of the inflammation along the optic nerve kind of made me think that this might be NMO, although I wasn't sure yet. So Anne got admitted to the hospital and she got 3 days of IV steroids. I'm sure many patients in the audience here have gotten steroids for MS relapse before. And typically, even without steroids, optic neuritis in MS patients, the vision will get better on its own. But with NMO, that's not the case. And unfortunately, in Anne's case, her vision did not get any better with the steroids. And while we were in the hospital, we talked about whether there are other treatment options if the steroids aren't helping. And we decided to go do another treatment called plasmapheresis, which is a little bit more invasive. It involves a catheter, and she had to stay in the hospital an extra week, actually, to get the plasmapheresis. And even then, when she followed up with me in clinic 2 months later, her vision didn't get that much better. So she was still, fortunately, 20/20 in her right eye, the good eye, but in the left eye, she only got to 2400. So now she could finally see the big E on the top of the eye chart, but still, that's legally blind in that eye. So neither of us were very happy with that. I mean, we're appreciative that she had some modest improvement, but based on that, I had a suspicion that she might have NMOSD. That's a tip off when patients have poor recovery from their optic neuritis. Now, there are rare cases in MS where that happens. So I do have MS patients who've had optic neuritis and they've had poor recovery. So it doesn't mean that it's always NMO, but that's just a suggestion that it might be. So what did we do? We did blood work, and lo and behold, she had this positive blood test called the aquaporin 4 antibody. And that's an antibody that we know is a marker for this disease. It's very specific for NMO, meaning it's very rare to get a false positive test. And we also did a spinal tap because, we know for MS that you can have inflammation in the spinal fluid. We call it oligoclonal bands. She did not have those. So because she had aquaporin 4 antibodies in her blood, in the setting of optic neuritis, she actually meets the diagnostic criteria for NMO. And I'll talk a little bit more about that later, the diagnostic criteria. 80% of NMO patients have the antibody. So it's, again, pretty specific and pretty sensitive. That does mean, though, that about 20% of patients who have NMO have a negative blood test. So it makes it a little harder to diagnose in those patients, but we can do it. Whereas MS patients should not have an aquaporin 4 antibody, because as I said, if it's a positive test, that means pretty much you have the disease. And NMO also rarely has oligoclonal bands in the spinal fluid. So 90% of patients with MS, if they have a spinal tap, will detect oligoclonal bands in the CSF. So those two tests were very helpful in solidifying the diagnosis. So you can see here, we look back before we had Devic in 1994 for describing it, and really took about 100 years to make the major advance that we did, that aquaporin 4 was the antibody associated with this disease. And there's two important takeaway messages about the aquaporin 4 antibody that I want you to remember. One is that it's a diagnostic marker of the disease. Again, 80% of people with NMO will have the antibody in their blood. But two, this antibody actually causes the disease. That's at least our understanding of it today, is that in the positive patients, this antibody actually causes the optic neuritis or the other inflammation in the central nervous system. What's the prognosis? So as I mentioned, prior studies from the Mayo Clinic have shown that after an average follow-up of about 8 years from disease onset, about half of patients were legally blind in one eye, and 15% were blind in both eyes. But some of these studies were done over 10 years ago before we had FDA-approved therapies. So how can we prevent this from happening to Anne? How can we prevent her from suffering vision loss in her good eye, the right eye? We'll talk more about that later, but keep that in mind. That's one of the pressing questions about NMOs. How do we prevent the next attack? So again, the recovery is poor, so that's always a tip-off. Somebody has optic neuritis, either if it's mild but recurs, we always think about NMO, and pretty much I test all my optic neuritis patients for it because the stakes are so high. And once you have the antibody, we know the risk of having a relapse is elevated. And it might not just be optic neuritis again. You could have one of the other manifestations of NMO, including transverse myelitis. Again, I mentioned this earlier. There's another study just highlighting the prognosis. 40% of aquaporin 4 antibody positive NMO patients are legally blind in at least one eye 5 years after disease onset. That's not something we typically see in MS. Most patients, if you have MS optic neuritis, your vision gets back, not maybe completely to normal, but close to normal. So over time, our understanding has expanded. We tested more and more patients, and we found more and more patients had aquaporin-4 antibodies. And when we found this, we actually expanded our understanding. It wasn't just optic neuritis and transverse myelitis, but there were other syndromes, and hence they changed the name from NMO in 2006. In 2015, they revised it and called it NMOSD, or neuromyelitis optica spectrum disorder, because it's actually a spectrum. There's optic neuritis and transverse myelitis, which are still by far the most common presentations, but there's these other syndromes like the area postrema syndrome. So where is NMOSD? Going back to those questions. So I mentioned the optic nerve. I'm going to talk a little bit about the spinal cord, and then I'll talk about the area postrema. So transverse myelitis is inflammation of the spinal cord. And again, it can be confusing because you can get transverse myelitis in MS, you can get transverse myelitis in NMOSD. But again, in NMO, it tends to be more severe. The inflammation is bigger and more extensive on the spinal MRI scans that we get, and I'll show you an example of that soon. 22% of patients with NMO require a walker after 5 years of disease onset, and 8% of patients within 5 years require a wheelchair. And again, that's just very rare in MS. Maybe temporarily you might need a wheelchair from MS if you had an attack early on of transverse myelitis, but usually with steroids and physical therapy, you'll be walking again close to independently, whereas with NMO, you can end up in a wheelchair from that very first attack. It's pretty severe. And about 50% of patients who have NMO, their first attack will actually be inflammation of the spinal cord. It's actually, even though I presented optic neuritis first, transverse myelitis is the most common initial manifestation for patients. And again, poor recovery is unfortunately common. So this is an MRI. This is showing here, I'm going to just highlight here, this white area where you see the inflammation in the spinal cord is all this transverse myelitis. This is more normal signal in the spinal cord where it's darker, and then with this bright white area. And we have different segments of the spine. So we're up in the neck area. So this is what we call the cervical spine. So we have C2, C3, C4. In MS, typically the inflammation is at 1 level, maybe 2 levels. Whereas you can see here in NMO, this is extending about 7 levels, maybe even longer. On the right, we can see the contrast enhancement. And what we have in NMO is something called longitudinally extensive transverse myelitis, typically. And that means that at least 3 segments or longer are involved in the spinal cord and the inflammation. And that's probably why the recovery is bad in this disease, because more of the spinal cord is inflamed and damaged from the NMOSD attack. And so there's more damage to the spine, leading to more disability. Now, what is this area postrema? I mentioned it a couple times, but it's a very small area of the brain here. So this is kind of close to where the brainstem meets the spinal cord. And it's a very important area because the blood-brain barrier here is not that strong. You might have heard of this. It's kind of a barrier that separates the brain and the central nervous system from the rest of the body. And it helps protect the central nervous system, but it's a little leaky here. And the area postrema helps control our nausea, vomiting, and hiccups, meaning if you get intractable nausea, vomiting, or hiccups, it could be due to inflammation in this part of the brain. There's cells that go from that part of the brainstem down to our gut that can cause intractable nausea, vomiting, or hiccups. And when I say intractable, I'm not talking about just being sick for a day, but I'm talking about days or weeks. Sometimes I'll have patients who are coming to me after they've had optic neuritis, and we're talking about their history, and they're like, yeah, 2 years ago, I was in the hospital for about a month. I had this terrible stomach illness. Nobody could figure out what was going on. They did CAT scans of my abdomen. They scoped me from above and below. The GI doctors couldn't figure out anything, and then it just got better. And then later on, I tested them. They were aquaporin-4 antibody positive. And in retrospect, they had the area postrema syndrome back then. This is just highlighting how other parts of the brain can be involved. So I mentioned that initially we were taught wrong or thought wrong, and we were mistaken that the brain was supposed to be normal in Devick's disease or NMOSD. But now we have a better understanding, and actually many different parts of the brain can be involved. And I'm not even showing you all of them, but I just want to highlight that sometimes the brain can be involved outside of the optic nerve in the spinal cord. And there are some differences that are subtle. Sometimes will be suggestive that it's NMO and not MS. But sometimes it's not so easy to pick it up. So that's why the blood test is so helpful. So why is there NMOSD? That's always a question. Why do I have this disease? So as with many autoimmune diseases, we don't know exactly why it occurs in any particular individual. So I don't know why Anne developed these aquaporin 4 antibodies that caused her NMOSD. But we're learning more about this disease all the time. And I just want to share a little bit of our understanding so far of why this occurs. So our immune system normally fights off infections. If you think about COVID, for example, right? So you get a virus, your body gets infected by the virus and your immune system fights the virus off. And then once the infection's gone, the immune system calms back down and just waits for the next virus or bacteria to come around to fight it off next. But with an autoimmune disease, your body's immune system, we think, mistakes your own body as a virus. It starts to think that your central nervous system is a foreign attacker. And so your immune system, in this case, apparently targets this water channel in the brain called the aquaporin 4 channel. So we call it the aquaporin 4 antibody because the antibody is targeting this protein in the central nervous system. And it's actually the most common water channel in the central nervous system. So it helps channel water through cells. And the cells in the central nervous system where most of these aquaporin 4 channels are on astrocytes, which you might not have heard of before. In MS, we talk about oligodendrocytes because those are the cells that make myelin, and those are important. We talk about neurons, of course, because the neurons are the main workers of the central nervous system. But the astrocytes are actually very important support cells in the central nervous system. And they get targeted by these antibodies. And if the astrocytes are damaged, that leads to secondary damage to the oligodendrocytes and the neurons. Really, our neurons can't survive without the astrocytes. So if all the astrocytes in the neighborhood get damaged, those neurons stop working. So for example, I'll go back to Anne's case in optic neuritis. The immune system is attacking the astrocytes in Anne's optic nerve. That's leading to the vision loss. So this is actually an interesting picture. I'm showing this because this is from a mouse. And what they did in the mouse is they actually mapped out where the aquaporin 4 is in the optic nerve. So if we look here, this is just a cartoon of the eyeball itself here. So this is the front of the eye. This is your cornea. The lens would be here. The back of the eye is the retina. And right in the back of the retina is the optic nerve, and that connects to the brain. And this is just a magnification of that picture. So if you look here, you have retina here. There's about a 90-degree turn as the nerves that exit the retina turn into the optic nerve. And then behind this thing called the lamina curvosa is the optic nerve. And that's basically, this is the eyeball, this is the central nervous system, this is your optic nerve here. So it's the same thing in the mouse, actually. This is the retina up here, this is that lamina curvosa, and this is the optic nerve. And if you look at all the green dots, that's aquaporin. So there's a lot of aquaporin in the optic nerve. You might even notice there's a little bit in the retina, which is true even in humans, but the bulk of the aquaporin 4 is in the optic nerve. And that's why if you have aquaporin 4 antibodies, you can get optic neuritis. This is just a cartoon showing what the astrocyte looks like. I mentioned the astrocyte. So if you look, there's these little blue colored silos or channels. Those are the aquaporin 4 proteins on the astrocyte. And the red Ys are the antibodies. So the red Ys are the aquaporin 4 antibodies. They bind to and attach to the aquaporin 4 channel on the astrocyte. And basically, once the antibody binds to the astrocyte, they invite the entire immune system come in and attack the astrocyte. So if you look on the top left, it says CDC, and there's all these letters. It says C2, C3, C4, C5, et cetera. That's a whole bunch of proteins called complement. Complement's involved in the immune system. We don't really talk about it a lot because it's not really something we talked about much before in autoimmune diseases, but we now recognize that it's critically important in leading the damage that occurs in NMO. So one of the drugs that we actually use to treat NMO blocks complement. You also see up here on the right a macrophage. That's another type of cell that can get into the party and damage the astrocytes. There's another cell highlighted on the right, the big yellow cell next to where it says ADCC, that's an NK cell or a natural killer cell. And if that sounds bad, that is, it's a natural killer cell. That's what it does, is it kills cells. And it's going in there and it's killing the astrocyte. And then finally on the bottom right, there's other cells, like it says eosinophil on the bottom part there. Eosinophils and neutrophils come in, they can also lead to damage. So you get all different parts of the immune system coming in targeting the astrocyte. And then once the astrocyte's damaged, they can go on. And once these cells are in there, if there's an oligodendrocyte next to it, they'll attack that. And if there's a neuron next to it, they'll attack that. And so I think because all these cells are getting attacked, that's why the damage is so bad and the disability is so bad in NMO. You have all these other cells from the immune system coming in and attacking astrocytes, oligodendrocytes, and neurons. And that's why you have such severe disability from this disease. So next, we're going to talk about who gets NMOSD. So it occurs in individuals of all races. The prevalence is approximately 1 to 10 people per 100,000, and it seems to be pretty similar worldwide, although patients from or individuals from countries of African ancestry, like the Caribbean, seem to have a higher proportion or higher rates of having this. What's really interesting, though, is the female to male ratio is 9 to 1. If we think about MS, the ratio is maybe about 3 to 2. So while females might be more commonly affected with MS, there are a lot of men with MS. Whereas with NMO, it's really predominantly a female disease. Although the last 2 patients I diagnosed happen to be men, 95% of the patients at the NMO clinic at Georgetown are female. In the US, the reported number is about 17,000 patients with NMOSD. I think this is a gross underestimation. There's about, just for comparison, about 1 million patients with MS. I think probably we're going to find the number of NMO patients is closer to maybe 50 or even 100,000 once we get better accurate numbers. And again, it's associated with this aquaporin 4 antibody, but I just want to emphasize that's about 80%. So about 20% of patients might be seronegative or not have the aquaporin 4 antibody. I'm not going to talk about MOG. That might be a talk for next year's patient education day, but that's another autoimmune disease that can cause optic neuritis that can be similar to NMO. And really what I want to emphasize that NMO is now separate from MS. Again, back when I was a resident, we've taught it was a bad variant of MS, a severe variant of MS, but it really is a separate and distinct disease from MS. And the treatment options are different. And I now have 3 FDA-approved therapies for NMOSD, which is amazing. But some of the medications that we used to use, or that we do use for MS, that we tried using in MO, actually might have aggravated it. It's only based on case reports, so it's not definitive, but there are a lot of case reports that patients who are on some of the MS medications, when they were found out to actually have NMO or known to have NMO, their NMO actually got worse. So now we don't use the MS medications for treating NMO, and I'll explain what the treatments are for NMO soon. And the other important thing is that it's a different disease course. So the prognosis for recovery is really not as good. You know, you might have a mild MS relapse, and we might not choose to treat it if it's just mild numbness. Whereas pretty much we have to treat every relapse in NMO because they tend to be quite severe, and that's where all the disability accrues, we think. So when should you treat NMOSD? Immediately. And I mean this urgently. This is not like, you know, some MS relapses, again, you might decide to skip treating. Here, you know, time is brain. So you really want to get the steroids on board as soon as possible. If steroids don't work, we frequently will use plasmapheresis. Again, that requires you to be in the hospital for an extra week. So it's a pretty serious disease and it's pretty serious treatments. Many times if patients have transverse myelitis, they're going to end up needing physical and occupational therapy. And if they've had optic neuritis with poor recovery, they might need a referral to an optometrist who specializes in low vision, because just normal glasses aren't going to help. But maybe some kind of adaptive devices will help our patients who have had significant vision loss from optic neuritis. So back to our timeline, going back to answering when. So 2019 was when the first FDA-approved therapy was approved for treating NMOSD. Prior to that, we had treatments that we used, but none of them were approved by the FDA. So it was kind of, I don't want to say the Wild West, but we just didn't have a lot of great options. Many patients still are treated with rituximab because it works pretty well, although it's still not FDA approved. But prior to 2019, I think Rituxan or rituximab was the most commonly used drug, and still might be, because the newer drugs have only been on the market for a few years. But the first drug that was approved was Soliris or eculizumab. And again, this is a drug that targets that part of the immune system I talked about earlier, complement. And they showed in a relatively large trial, for NMO was large, that by blocking complement, they could block relapses of NMOSD. So it's approved only for adults who are aquaporin 4 positive. So if you're seronegative or don't have the antibody, it's not approved for that. And it's infused every 2 weeks. So it is a frequent infusion, although it's only 35 minutes. The major caveat with this drug is it can increase the risk of infections, particularly something called meningococcal disease. So to help prevent that, you have to get vaccinated. There are 2 vaccines that you would get prior to starting therapy. No vaccine's perfect, as I'm sure we're all well aware from the pandemic, but the vaccines do significantly reduce the risk of getting that bacterial infection of meningococcal meningitis. 2 other medications were shortly thereafter approved by the FDA. One of them was called satralizumab or Enspryng. This is actually self-injected, so you can take this at home. It's another monoclonal antibody. It blocks a part of the immune system called interleukin-6, and it's injected by the patient or a caregiver every 4 weeks. Again, because you're modulating this immune system, there might be a slight increased risk of infection, so you have to monitor for that. And obviously, because you're self-injecting, you might get some injection site reactions. And lastly, Uplizna or inebilizumab is a monoclonal antibody that targets another part of the immune system called B cells. B cells are important because they actually are the cells that make the antibodies that make aquaporin 4 antibodies. So the thought is if you target the B cells and you deplete them, then you might diminish the amount of aquaporin 4 antibodies and halt the disease from having relapses. This drug is infused every 6 months, kind of similar to rituximab in that respect, but it also may increase the risk of infections. So you have to watch out for that. Now, the risk of infections is generally low with these drugs, whereas the risk of relapse from NMO is quite high. So clearly, I think with all 3 drugs, the benefits far outweigh the risks. Again, I just want to emphasize this because the risk of relapses and disability is so high in NMOSD, it's recommended that all patients stay on some form of long-term therapy to prevent attacks and relapses. Unfortunately, once an attack occurs, it's hard to recover from it. So, if I put Anne on one of these 3 drugs, it's not going to get her vision back that she lost in her left eye. That vision loss in her left eye is unfortunately probably going to be permanent. But the idea is to prevent her from going blind in the right eye or prevent her from ending up in a wheelchair. So you have to have realistic expectations for what these drugs are going to do. And really the name of the game in this disease is prevention of future attacks with the medications that modulate the immune system. So unfortunately for aquaporin 4 negative patients who don't have antibodies, there's no FDA-approved therapies yet. So many of these patients still get other drugs that target the immune system. As I mentioned, there's rituximab, there's mycophenolate, which is a pill or known as Cellcept or azathioprine. These drugs seem to do a fairly good job also of treating patients, although unfortunately, we don't have as good of data because it's a smaller subset of a rare disease. One thing I'll let you know, though, is that there are different types of blood tests for the aquaporin 4 antibody. One of the most common ones available is the ELISA assay, which is good, but it's not great. The cell-based assay is better. Now, I don't expect you to know what kind of blood test you're getting, but your doctor should know. And if your first test wasn't a negative test, you could ask your doctor, hey, by the way, was that an ELISA? Because maybe we could resend it to a cell-based assay. And that's what we do at Georgetown. We can send our cell-based assays off to the Mayo Clinic, which actually discovered the antibody, and they have one of the best tests for it. And sometimes it happens where the negative test turns into a positive test. So somebody who you thought maybe didn't have a positive antibody turns into having one. And that's important for 2 reasons. Again, 1, it will confirm the diagnosis. And 2, it will open up treatment options because all the treatment options we have are, again, approved for aquaporin 4 positive patients. So although there's a lot of disability associated with this disease, this really is a great time for NMOSD. We have 3 highly effective treatments for this disease, and there's more treatments coming down the pipeline. And so I just want to leave on with hope, basically. I think this is really amazing time. I remember patients that I treated with as a resident who, were severely disabled by this disease, and we didn't have any great treatment options. And now, I get to sit down and talk to patients when they get diagnosed about these different treatment options. And it's really an amazing time that we live in with all the scientific advances. If you have other questions, you want to find out more information, I think we alluded to this earlier and it's on the website, but you can go to the Guthrie-Jackson Foundation or the Sumaira Foundation. They are great resources for learning more about NMOSD. And with that, I will say thank you. And yeah.
Thank you so much, Dr. Osborne. So we now will have a break and we do have some special sponsor spotlights to show here in the webinar, and then a reminder that you can also exit out of here and go back to the sponsor pages in the exhibit hall. So go ahead and share my screen for everybody so that you can view our spotlights. Oh, and we'll meet back here at 10 a.m. for our next presentation.
Hi, I'm Sarah, and I have MS. I like to work out. I like to spend time with my boys. My boys are very active, so they play soccer. We're at the soccer field a lot, and at the school helping out as well, field trips, all that fun stuff. I was starting my career in healthcare administration, driving home from work one day, and all of a sudden was experiencing blurry vision in my right eye. Had no clue what was happening to me. Immediately consulted with my mom, who is in the healthcare industry. I went and saw an ophthalmologist, who in turn referred me to a neurologist, who ordered the testing that resulted in the diagnosis of multiple sclerosis.
When Sarah first told me the diagnosis of MS, I was shocked. I was afraid for her.
It was very frightening, I didn't know what the future was going to hold for me. The injectable medication that I was prescribed was very daunting to have to take and inject. I did that multiple times per week, regularly, for 3. Hi, I'm Sarah, and I have MS. I like to work out. I like to spend time with my boys. My boys are very active, so they play soccer. We're at the soccer field a lot, and at the school helping out as well, field trips, all that fun stuff. I was starting my career in healthcare administration, driving home from work one day, and all of a sudden was experiencing blurry vision in my right eye. Had no clue what was happening to me. Immediately consulted with my mom, who is in the healthcare industry. I went and saw.
I'm so sorry, you all, for the technical difficulty. We will restart the video now. Okay.
Hi, I'm Sarah, and I have MS. I like to work out. I like to spend time with my boys. My boys are very active, so they play soccer. We're at the soccer field a lot, and at the school helping out as well, field trips, all that fun stuff. I was starting my career in healthcare administration, driving home from work one day, and all of a sudden was experiencing blurry vision in my right eye. Had no clue what was happening to me. Immediately consulted with my mom, who is in the healthcare industry. I went and saw an ophthalmologist, who in turn referred me to a neurologist, who ordered the testing that resulted in the diagnosis of multiple sclerosis.
When Sarah first told me the diagnosis of MS, I was shocked. I was afraid for her.
It was very frightening, I didn't know what the future was going to hold for me. The injectable medication that I was prescribed was very daunting to have to take and inject. I did that multiple times per week regularly for 3 years. In that time, I had gotten married and were deciding to have children, so went to visit the neurologist and we discontinued the injectable.
After having 2 healthy, beautiful boys, Sarah was reluctant to really think seriously about the MS. She did begin to develop some symptoms, and it was at that point that I said, hey, you've got to go back to your neurologist. You've got to see what's going on.
A few years back when I had an MRI, it revealed that I still, in fact, had multiple sclerosis. My neurologist then discussed with me the different treatments that were available and decided that I would begin on the once-a-day Zeposia.
Zeposia may cause serious side effects, including infections that can be life-threatening and cause death, progressive multifocal leukoencephalopathy, PML, slow heart rate, liver problems, increased blood pressure, breathing problems, i.e. shortness of breath, macular edema, a vision problem, swelling and narrowing of blood vessels in your brain, severe worsening of multiple sclerosis, MS, after stopping Zeposia compared to before or during treatment. These are not all the possible side effects of Zeposia. Please see important safety information available at the conclusion of this video for common side effects reported by those taking Zeposia.
I like using Zeposia because it's a once daily pill. I haven't had any relapses, so things have been going really well.
We're now 3 MRIs later, and all of them have been stable. So that's pretty exciting.
I'm hopeful for my future. I'm excited about the future. So I'm very glad that my doctor chose to start Zeposia to treat my MS.
Indication. Zeposia, ozanimod, is a prescription medicine used to treat relapsing forms of multiple sclerosis, MS, to include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease in adults. It is not known if Zeposia is safe and effective in children. Important safety information. Do not take Zeposia if you have had a heart attack, chest pain, unstable angina, stroke or mini-stroke, transient ischemic attack or TIA, or certain types of heart failure in the last 6 months. Have or have had a history of certain types of an irregular or abnormal heartbeat, arrhythmia, that is not corrected by a pacemaker. Have untreated severe breathing problems during your sleep, sleep apnea. Take certain medicines called monoamine oxidase, MAO, inhibitors, such as selegiline, phenelzine, linezolid. Talk to your healthcare provider before taking Zeposia if you have any of these conditions or do not know if you have any of these conditions. Zeposia may cause serious side effects, including infections. Zeposia can increase your risk of serious infections that can be life-threatening and cause death. Zeposia lowers the number of white blood cells, lymphocytes, in your blood. This will usually go back to normal within 3 months of stopping treatment. Your healthcare provider may do a blood test of your white blood cells before you start taking Zeposia. Call your healthcare provider right away if you have any of these symptoms of an infection during treatment with Zeposia and for 3 months after your last dose of Zeposia. Fever, feeling very tired, flu-like symptoms, cough, painful and frequent urination, signs of a urinary tract infection, rash, headache with fever, neck stiffness, sensitivity to light, nausea, or confusion. These may be symptoms of meningitis, an infection of the lining around your brain and spine. Your healthcare provider may delay starting or may stop your Zeposia treatment if you have an infection. Progressive multifocal leukoencephalopathy, PML. Zeposia can increase your risk for PML, which is a rare brain infection that usually leads to death or severe disability. If PML happens, it usually happens in people with weakened immune systems, but has happened in people who do not have weakened immune systems. Symptoms of PML get worse over days to weeks. Call your doctor right away if you have any new or worsening symptoms of PML that have lasted several days, including weakness on one side of your body, changes in your vision, changes in your thinking or memory, confusion, changes in your personality, loss of coordination in your arms or legs, decreased strength, and/or problems with balance. Slow heart rate, also known as bradyarrhythmia, when you start taking Zeposia. Zeposia may cause your heart rate to temporarily slow down, especially during the first 8 days. You will have a test to check the electrical activity of your heart called an electrocardiogram, ECG, before you take your first dose of Zeposia. Call your healthcare provider if you experience the following symptoms of slow heart rate: dizziness, lightheadedness, feeling like your heart is beating slowly or skipping beats, shortness of breath, confusion, chest pain, tiredness. Follow directions from your healthcare provider when starting Zeposia and when you miss a dose. Continue reading for additional possible serious side effects of Zeposia. Before taking Zeposia, tell your healthcare provider about all of your medical conditions, including if you have a fever or infection, or are unable to fight infections due to a disease, or take or have taken medicines that lower your immune system. Received a vaccine in the past 30 days, or are scheduled to receive a vaccine. Zeposia may cause vaccines to be less effective. Before you start Zeposia, your healthcare provider may give you a chickenpox, varicella zoster virus vaccine if you have not had one before. Have had chickenpox or have received the vaccine for chickenpox. Your healthcare provider may do a blood test for the chickenpox virus. You may need to get the full course of the vaccine and wait 1 month before taking Zeposia. Have a slow heart rate. Have an irregular or abnormal heartbeat, arrhythmia. Have a history of stroke. Have or have had heart problems, including a heart attack or chest pain. Have high blood pressure. Have liver problems. Have breathing problems, including during your sleep. Have eye problems, especially an inflammation of the eye called uveitis. Have diabetes. Are or plan to become pregnant, or if you become pregnant within 3 months after you stop taking Zeposia. Zeposia may harm your unborn baby. If you are a female who can become pregnant, talk to your healthcare provider about what birth control method is right for you during your treatment with Zeposia and for 3 months after you stop taking Zeposia. If you become pregnant while taking Zeposia, tell your healthcare provider right away and enroll in the Zeposia Pregnancy Registry by calling 1-877-301-9314 or visiting www.zeposiapregnancyregistry.com. Are breastfeeding or plan to breastfeed. It is not known if Zeposia passes into your breast milk. Talk to your healthcare provider about the best way to feed your baby if you take Zeposia. Tell your healthcare provider about all the medicines you take or have recently taken, including prescription and over-the-counter medicines, vitamins, and herbal supplements. Using Zeposia with other medicines can cause serious side effects. Especially tell your healthcare provider if you take or have taken medicines that affect your immune system, such as alemtuzumab, medicines to control your heart rhythm, antiarrhythmics, or heartbeat, CYP2C8 inducers such as rifampin, CYP2C8 inhibitors such as gemfibrozil, medicine to treat high fat in your blood, opioids, pain medicine, medicines to treat depression, and medicines to treat Parkinson's disease, medicines to control your heart rate and blood pressure, beta blocker medicines, and calcium channel blocker medicines. You should not receive live vaccines during treatment with Zeposia for at least 1 month before taking Zeposia and for 3 months after you stop taking Zeposia. Vaccines may not work as well when given during treatment with Zeposia. Zeposia can cause serious side effects, including liver problems. Your healthcare provider will do blood tests to check your liver before you start taking Zeposia. Call your healthcare provider right away if you have any of the following symptoms: unexplained nausea, vomiting, stomach area, abdominal pain, tiredness, loss of appetite, yellowing of the whites of your eyes or skin, dark-colored urine, increased blood pressure. Your healthcare provider should check your blood pressure during treatment with Zeposia. A sudden severe increase in blood pressure, hypertensive crisis, can happen when you eat certain foods that contain high levels of tyramine. Breathing problems. Some people who take Zeposia have shortness of breath. Call your healthcare provider right away if you have new or worsening breathing problems. A problem with your vision called macular edema. Your risk of macular edema is higher if you have diabetes or have had an inflammation of your eye called uveitis. Your healthcare provider should test your vision before you start taking Zeposia if you are at higher risk for macular edema or anytime you notice vision changes during treatment with Zeposia. Call your healthcare provider right away if you have any of the following symptoms: blurriness or shadows in the center of your vision, sensitivity to light, a blind spot in the center of your vision, unusually colored vision, swelling and narrowing of the blood vessels in your brain, posterior reversible encephalopathy syndrome, PRES, is a rare condition that has happened with Zeposia and with drugs in the same class. Symptoms of PRES usually get better when you The most common side effects of Zeposia can include upper respiratory tract infections, elevated liver enzymes, low blood pressure when you stand up, orthostatic hypotension, painful and frequent urination, signs of urinary tract infection, back pain, high blood pressure, headache. These are not all of the possible side effects of Zeposia. For more information, ask your healthcare provider or pharmacist. Call your healthcare provider for medical advice about side effects. You may report side effects to FDA at 1-800-FDA-1088. Please see full prescribing information, including medication guide.
Please view this additional sponsor spotlight as well as the virtual exhibit hall. And again, our next presentation will begin at 10 a.m. Welcome back, everybody. It's 10 a.m., so we'll get started again. We hope you enjoyed the sponsor spotlights. Again, sorry for my technical difficulty. You think this would be second nature after 3 years of the pandemic. But we also hope that you got to see the virtual exhibit hall some. If you did not, don't worry. This site will remain up for 6 months, as we mentioned before, and you'll be able to visit the virtual exhibit hall and view these lectures. Next up, we have David Pisville presenting a clinical trials update. David is the Associate Director of Clinical Trials at Georgetown. His research trials primarily focus on multiple sclerosis and neuromyelitis optica spectrum disorder. In addition to working at Georgetown, David also volunteers as an English-Spanish interpreter at a local free clinic. So he's going to talk to us more about our clinical trials program and opportunities. I will stop sharing, David, so you can take it away.
Awesome. Thank you, Bethany. And I'm now sharing my screen. All right. Welcome back, everyone. And thank you once again for joining us this morning. And a big thank you to Bethany Schreiber and everyone behind the scenes who worked so hard to make this event possible. My name is David Pisville, and I'm an Associate Director of Clinical Trials in the Department of Neurology. Today, I will have the pleasure of sharing information about clinical trials with you all. I will first give you a little bit of background as to what a clinical trial is, how they take place, and I will end with a brief description on our enrolling studies at Georgetown. On this slide, I'd like to introduce you to our research team, which has grown significantly in the past year and is comprised of a group of directors, several clinical trial coordinators, both of us who would be your typically both of us would be your primary point of contact for study participants and student research assistants as well. So in order to understand a clinical trial, I think it's important to know why they are being conducted, which is because researchers are looking for answers with the help of volunteers like you to learn more about efficacy of new therapies. And it's important to note that all drugs that we have today are thanks to participants in clinical trials. Without the participants, we would be unable to learn about new treatments to help patients. And so a big virtual round of applause and thank you to anyone listening who is participating in clinical trials. These studies play an important role in improving healthcare because the results at the end of these studies help better understand conditions like MS, NMO, and MOGAD. So how do you know if joining a study is the right decision for you or a loved one? First, we advise you to check that the study is intended for your specific condition and reference the guidelines for eligibility criteria. Every trial has unique guidelines for who can participate in a specific study so that researchers can understand the results of clinical trials and for the safety of participants as well. We refer to these guidelines as eligibility criteria. Typically, this includes characteristics such as age, medical history, or as Dr. Amjad mentioned earlier, a scaled assessment called the EDSS. And it's also important to weigh out your options. Two major benefits of enrolling in clinical trials are one, it allows patients to obtain access to novel therapies that are not available as standard treatments, not on the market yet. And two, it allows patients to participate in generating knowledge about the disease that can impact other patients' lives as well. And it's also important to note that participation in a clinical trial can add to an already full schedule. A study protocol may require you to commit to additional on-site visits, but every study is different in that aspect and it will vary. So if you would like to learn more about a specific study or you believe you may qualify for one, please contact our study team to discuss any questions that you may have. And of course, I will share my contact information at the end of this presentation. We can be reached via email or phone for more information, again, on enrollment opportunities and study-specific informed consent forms, or ICFs. An ICF is a document that explains the purpose, procedures, and any potential risks and benefits of the trial. I'd like to note that the informed consent is a critical step in clinical trials. It is a process that helps patients make an informed decision about whether to participate in a study. And we encourage all patients to take the time to review this consent form with their care team, loved ones, and any other supportive figures in their lives before making a decision. We also like to emphasize the point that participation is completely voluntary and your personal medical information is kept confidential. So after completing the consent process, we proceed with screening you or anyone for the study to ensure that the patient meets all eligibility criteria. And again, this is for safety purposes and the validity of a trial, of a study. Our team then schedules you to come on site for a screening visit to review medical records, perform several health assessments, and complete a neuro and physical exam. And this is all to determine that the results match the study criteria. And it is okay if you don't meet the criteria for a study. That does not exclude you from pursuing other studies that might be a better fit. So once we confirm eligibility, we proceed with research visits according to the protocol, which again varies for every study. And during the study, we are sure to monitor your health and make note of any adverse effects experienced at any point and any changes to your health while receiving the study treatment. And this is done until your final evaluation at the end of the study. Within our team in the neurology department, we have about 65 ongoing studies. Of those 65, there are 6 currently enrolling for multiple sclerosis patients, 1 for NMOSD and 1 for MOGAD. I invite you to visit our website, neurology.georgetown.edu/GUNCR, where you can stay up to date with any currently enrolling studies. Here is a screenshot of that website. When you arrive to the site, you will have the option to select your condition of interest. As you can see here, the cursor has selected multiple sclerosis. And all of our enrolling studies will then be listed with the appropriate point of contact. So these are a list of the studies that are currently enrolling and who you can reach out to. And then each hyperlink can take you to the clinicaltrials.gov website, where you can find more study-related details. So now I'd like to elaborate a little bit more on the different types of studies that we have, interventional and observational trials. Interventional trials test a potential therapy, so participants are assigned to either placebo or an investigational product, and the purpose of these trials is to determine the effectiveness most of the time of a potential therapy. While participants in observational studies are being observed over time and not taking necessarily any study treatment. And in general, these studies are used to learn more about trends in disease progression or in therapy regimens. I think observational trials are a great option for anyone who may be hesitant about starting a study drug, but would still like to be involved in a clinical trial. Here I have compiled a diagram to help us categorize our interventional studies. So just a reminder, we are administering some sort of study medication for these. On the left, you will see the studies that are currently enrolling for primary progressive MS or PPMS. And to the right, you will have you'll see the studies currently enrolling for relapse remitting MS or RRMS. And so branching off here, starting with PPMS, we have OHAND, This study is a double-blinded study, meaning that neither the study team nor the participant know which arm they are randomized to. And it's looking to evaluate the efficacy and safety of ocrelizumab or Ocrevus compared with placebo, and specifically focusing on upper limit disability progression. Next, the Ventrepid study is another double-blinded study evaluating the efficacy and safety of a newer type of MS therapy called a BTK inhibitor, most specifically called fenebrutinib. All eligible participants will be randomized to take either fenebrutinib or ocrelizumab for this study. So moving on here to the right, through RMS, we have Enlighten, which is a single-arm trial studying the change in cognitive processing speeds in patients treated with Zeposia or ozanimod, which we just heard about during our break. Next, we have Treat MS, which is a standard of care trial. So no study drug is provided for this study, but we are looking at whether an early aggressive therapy approach versus starting with a traditional therapy influences the risk of disability. So participants will be randomized into one of those arms of the study. And last study here, FENHANCE, it's a randomized double-blinded trial comparing fenebrutinib, so again, the same medication mentioned previously, to Aubagio, an already approved MS therapy. And then if you look down here, we have one study we currently have enrolling for NMO. It's a pediatric study called NMO 303. It's a trial for eculizumab infusions in pediatric patients between the ages of 2 to 17. And if you recall Dr. Osborne's presentation, this medication is actually already approved for adults with NMOSD. And last but not least, for MOGAD, the Meteoroid trial is a randomized double-blinded study comparing stratalizumab with a placebo. I also would like to mention that this list is constantly changing. We have several studies in the pipeline, and when they are open to enrollment, we update our website, and you might hear about them from your treating physician as well. All right, and same diagram format here for our observational trials, which are both currently for MS patients. MS Link is a program looking to collect health data through online surveys and well-being diaries, along with medical histories from participants. This information gets entered into a web-based participant portal with the goal of gathering data across a more diverse group of people living with MS, and to help researchers develop ways for providers to see a more complete picture of their MS patients. And finally, here we have Experience, which is looking to enroll participants who are receiving Vumerity, which is also an approved MS therapy, to further study safety, tolerability, and effectiveness. As a site, we are committed to overcoming barriers to participation in clinical trials. I invite you to stay up to date with our website, as previously mentioned, to stay informed of any trials that you may have questions about. Also, feel free to ask about any support options available to you. If you have concerns about the logistics of enrolling in a study, we are here to help and answer any questions you may have. For example, if you are concerned about mobilizing yourself to Georgetown, some trials reimburse parking or collaborate with vendors to provide you with travel arrangements. So just reach out and we'd be happy to address your concerns. And of course, as mentioned before, the informed consent process is an enormous, we prioritize that greatly, and our goal is to supply you with all of the information you need in order to make a decision during this process. So if you or someone you know is a Spanish speaker, we are excited to offer translated ICFs and study materials to our patients as well. And all of these documents have been approved by our institutional review board. So it's a really great resource to have for patients. So please don't hesitate to contact with me with any questions you may have about anything you heard today. Getting to know and assist patients is one of my favorite aspects of working in research, and I would be delighted to assist however I can. My contact info is on this slide, including a QR code you can scan that will take you to our website and also serves as a virtual business card, which I hope works for everyone. And if you scan this barcode and go to the site, you can actually look through all of the trials that I just discussed. So I know it was a lot, so you can stay up to date that way. And I'll also be available during the Q&A session at the end of today's event in case you have any questions. Thank you. Thanks so much.
Thank you, David. All right. So this year we are extremely happy to welcome Elizabeth Parker, who is a recreation therapist in the Adaptive Sports and Fitness Program at MedStar National Rehabilitation Hospital. And she is going to talk to us today about the Adaptive Sports and Fitness Program and how to get involved. So thank you, Elizabeth.
Thank you. I'm going to go ahead and share my screen. Okay. So I just wanted to say thank you for inviting me. My team is always super, super excited to share opportunities for participation in our programs. So I'm super excited to tell everyone more today. So first, I want to introduce you to my team, which is made up of the Therapeutic Recreation Department at MedStar National Rehabilitation Hospital. We are all board certified therapeutic recreation specialists, and we kind of always joke that we wear multiple hats in our jobs. So we actually all work inpatient at the rehab hospital. And usually when I'm telling or giving this presentation in person or even sometimes virtually, I kind of get looks like, what is recreation therapy? So I always like to give people a little bit of context. And so recreation therapy is a systematic process that uses recreation and other activity-based interventions to address the assessed needs of individuals with disabilities, kind of as a mean to psychological, physical health, kind of whole person recovery and well-being, which leads kind of perfectly into that adaptive sports and fitness world that we are a part of. So kind of on the website, this is our overview, our mission and our vision, which is to help maximize participation for individuals with disabilities in recreation and competitive sports. We're always hoping to build self-confidence, improve health and well-being, and gain greater independence. One of our big goals is to kind of reduce barriers to participation in our activities and our sports. So to tell you more, I'll probably say it many times because it is something that we always like to kind of make sure that everyone is aware of, is that there's no cost associated with our programs. We find that that can be one of the biggest barriers to participation for people, is that some of the equipment that you see within adaptive sports and fitness is just so costly. And so that's kind of huge for us, is that we're able to provide all equipment, all instruction, coaching, and for free. So all of our programs are located within the DC, Maryland, and Virginia area. We have both competitive opportunities within team sports and then recreation opportunities as well. We have programs that are held on site at the rehab hospital just down the street, kind of down the street from Georgetown. But then most of our other programs are held at community partnership locations within the DC, Maryland, and Virginia area. So when I give kind of an overview of some of our programs, I'll let people know what site these programs are held at. So just kind of to reiterate, our programs are specifically for individuals with physical disabilities and neurological health conditions. You don't have to be a patient of MedStar Health to participate. So anybody in the community can come and participate in our programs. And you don't have to live within the DC and Maryland, Virginia area either to participate in our virtual programs. So some of our community partnership locations are at DC Parks and Rec locations. So rec centers kind of all around the DC area. We partner with Maryland National Capital Planning Commission. So we have access to DC or to Maryland parks and recreation centers as well. And then we are also able to kind of work with the DC Office of Disabilities, United Spinal Metro DC chapter, and then other locations such as universities and local schools as well. So this is kind of an overview of our adaptive sports programs. On the left side of the screen, you'll see wheelchair basketball, wheelchair rugby, and sled hockey. And those are our competitive team sports that we offer. So they do participate in kind of national organizations. So our wheelchair basketball team is associated with the National Wheelchair Basketball Association. But you don't have to be interested in competing at a competitive level to try these sports out. So I'll tell you guys more a little bit about each one of them. But then on the right side of the screen, we have more of our recreation-based sports. So bocce, adaptive cycling, adaptive rowing, and wheelchair tennis. So our first one is wheelchair basketball, and that is the competitive sort of team. It's primarily played by individuals with lower extremity impairments. We have weekly practices. We host tournaments. So we'll be hosting a local tournament coming up in December. As with most of our sports, we typically have people reach out directly to the program coordinator. So the email is listed on this screen, but it can also be found on our website. And that's how we have people come out and try it out. So we wouldn't have beginners participate in a tournament or in a game, but we would have people come out and try it out at a practice. And that would be kind of the same situation with wheelchair rugby as well. This sport is primarily played by individuals who have impairments in at least 3 out of 4 of their limbs. There's weekly practices, travel opportunities, but what's even more unique, we have so much interest in wheelchair rugby that we actually have 3 different teams right now. So we have kind of an A, B, a B team, and then a completely beginner team as well. So it's just a great opportunity to kind of check out a different sport. Our sled hockey team is unique. It is an all youth team, but still kind of good information to know about, primarily played by individuals with lower extremity impairments. And it's kind of exactly what it looks like. You have picks on the bottom of your stick and you kind of push yourself on the ice. Our bocce program is a great program. This is now we're moving into more of our recreational based programs. This is held on site at MedStar National Rehabilitation Hospital. It's held every Thursday from 4 to 6, and all ability levels are welcome to do it. It's very unique. It's kind of almost, it can be played on different surface levels. You might see it at the beach, or just outside in the backyard, or kind of on a driveway as well. There's 3 different color balls, and it's almost like a target game as well, but it's really, really fun. It's a great community aspect, and it's paired on a day of the week that there's also a fitness program that happens locally at the hospital right afterwards. So there's opportunities for multiple things to participate in. Our next program is wheelchair tennis. This is open to beginners, youth, adults, kind of people, all ability levels, all skill levels. It's held on weekends in College Park, Maryland. So this is one of our community partnership locations. It's held on the campus of University of Maryland on Sundays from 1 to 4. And this is also, we have people that have never tried tennis before ever, and we have people who are very competitive tennis players. So all ranges are welcome. And a great opportunity to kind of get moving and have that community aspect. Adaptive rowing, we have indoor and outdoor seasons. This is also a great fitness opportunity to kind of stay in shape in the off season as well. It's held down at Anacostia Community Boathouse, but then during the indoor season, we have rowing opportunities at the hospital in DC. Adaptive cycling is another great program to be involved with. It is held in College Park too, at the same location as our wheelchair tennis program. So it is held in the morning on Sundays from March to November, and all ability levels are welcome. This is very adaptable. We kind of meet people where they're at to make it work. We have hand cycles, so you're operating the bike with your upper extremities, and we have leg bikes as well, where you're operating it with lower extremities. We have very cool adaptations that we can, again, meet somebody where they're at. So maybe steering with your shoulder, or if you can only brake on one side, using one side of your body, we kind of meet someone, assess them, and figure out a way to make it work. This is held on the same day as our tennis program, so it gives people an opportunity to try out or participate in multiple programs, which is very, very cool. We also have youth adaptive sports camp opportunities. So we always kind of share this with all audiences, just because everyone is so well connected and can share it with people who might be interested. But this is kind of an opportunity for youth ages 5 and up to try out all different equipment, all different sports opportunities, and work with each other and peers that are in similar situations that they might be in. So now we're moving into our adaptive fitness program, which is really huge and a great opportunity for all people to participate in. We provide weekly events for individuals with neurological disabilities to really work on physical fitness and functioning. I always tell people that this is a great way to supplement therapy. So unfortunately, we know that we can't always get as much physical therapy, occupational therapy as we might need or want, or there's insurance barriers, and this is a great way to participate. So we have skilled trainers and staff. Our fitness opportunities are in a group setting, so it's really great for social engagement. And then with the pandemic, we began offering programs virtually, which we've continued to do now that we're back in person as well, just to kind of open up the ability to participate in a lot of different fitness. So some of the examples of the things that we do: high intensity interval training circuits, we do boxing classes. What's unique about us is that we have a lot of specialized equipment that's not necessarily found in community settings, like a gym down the street. So we have standing frames, FES bikes, a lot of the equipment that you would maybe see in a therapy gym. We have access to be able to utilize that within our fitness programs. We offer adaptive yoga, Love Your Brain Yoga, which is an organization for individuals with brain injuries. And then we also, on a rotating basis, offer classes for specific diagnoses and populations. So at the end of this PowerPoint, I have kind of all of the links to where you can find the most updated information. And on the next slide, I'll share with you our current fitness offerings that we have. But the best way to kind of stay informed is to check the website to see what are we offering right now in terms of fitness programs. So right now, on Tuesdays, we're offering 2 in-person classes. So a functional upper extremity group, so primarily focusing on upper extremities, and this is run by volunteer occupational therapists. And then we are also offering circuit training and open gym. So this is that high intensity interval training and kind of access to that specialized equipment that I was talking about. On Wednesdays, we offer a virtual adaptive boxing class, which is great because you can do it from anywhere or any part of the country. On Thursdays, after our bocce program that's held at the hospital, we're offering a self-defense based fitness class. So it's jiu-jitsu, and it's in person, and that's brand new and has been very popular. And then on Saturdays, we are offering our 4-hour open gym time, which is again that high intensity interval training in the specialized. And then we are also offering an in-person and virtual moving and grooving class, which is a class that's kind of exactly what it sounds like. It is run by one of our board certified music therapists, who's also a fitness instructor. And so it is incorporating the music and fitness into one class together. At all times of the week, we are also partnering with the Spirit Club of Washington, D.C. to offer virtual classes. So the instructions on the bottom of this slide are how to sign up, but it can also all be found on the website. One thing I will add too is that it's a common question that we get. You do not have to have a physician note or order or prescription to participate in our programs. What we typically have people do is reach out specifically to our program coordinators just to kind of check in prior to registering for their first class. And we screen people just to make sure that they would be a good fit for the program, and then you can come out and participate. Another very common question that we get asked is how in the world could our programs be free? And so we actually raise all of our money through a yearly 5K that we hold every September called the Super H 5K. And this year it just happened and we were able to raise over $100,000 for our programs. And this is another kind of yearly great way to be involved. People push the race, use their power wheelchairs, they use adaptive cycles. All ability levels are welcome. It's a great way for our whole adaptive sports and fitness community to come together and celebrate what we can do to raise money. So this is kind of the best way to stay connected and to learn more. We are on social media, as we are recognizing that that is such a great way to stay connected with everyone. We have a newsletter. So if you sign up for our newsletter, we promise we won't spam you with emails. It'll only be opportunities to participate. Absolutely feel free to reach out to me directly with any questions or information. And then another way that we just love to tell people to kind of stay educated and involved in the adaptive sports community is to watch documentaries that we have that are available on Netflix and Amazon Prime. This is just a great way to learn about all different spectrums and levels of involvement in the adaptive sports world. So I know that that was a lot of information and I did kind of blitz through it, but unfortunately I can't stay till the end. So I did want to leave enough time for if people had specific questions about any of the programs or adaptive sports and fitness in general.
Those are some amazing programs. Thank you so much, Elizabeth. So I'll just give people a few minutes here if they have any questions for Elizabeth to go ahead and type those into the Q&A chat. We'll just give it a few minutes.
Yeah, no problem.
I've actually seen one of those documentaries that you put up there.
Yeah. My contact info here, let me put it back up on the screen. To repeat it, it's elizabeth.v.parker@medstar.net. And I think that I can type it in the chat as well. It can also be found everywhere, or it could be found, all of our contact information can be found on the MedStar Health website. If you just Google MedStar Adaptive Sports and Fitness, it'll come up and it'll list everyone's contact information. I also see a question about where the classes are available. So that's a great question. So we provide them both. So for the fitness classes are both virtually and then also in person at MedStar National Rehabilitation Hospital. And then for the other programs, they're either located at National Rehab Hospital as well, or at our community partnership locations, but all programs are held within the DC, Maryland, and Virginia area. And we also don't have any programs that are outside of the metro access range or near a metro site. So to make sure that transportation is accessible for everyone.
All right. Well, thank you.
Yeah, thank you.
There are no more questions. Thank you for joining us, Elizabeth. And I'm sure many of you know our next speaker, who is Kimberly Foster. Kim has a wide range of experience as a social worker. However, most recently, she was the social worker in our MS and neuroimmunology clinic at Georgetown. So she has been taking some time off to travel, but we're so happy she could join us today, and she's going to help us all decompress with a guided meditation. Thanks, Kim.
You're welcome. Good morning, everybody. I'm so excited to be back at Georgetown to spend a few minutes with you. And I hope that everybody's having a great day. I think it's fabulous, and everybody should congratulate Bethany for setting all this up for us. And so today, what I'd just like to do is a guided meditation. We'll just do a few minutes. And when I was at Georgetown, we did a guided meditation every week. And so we'd have different people join. And so I look at it as a great way to just take a few minutes to calm our brains and our bodies, and it helps calm your heart rate down. And also can be a good way to check in with your body and different parts of your body to see, how am I really feeling today? What part of my body might be hurting or aching? What feels really good? Often we would do it at lunchtime, and it would be checking in with our body about, do I need to eat? Do I need to hydrate? Do I need to take a break and use the restroom? Or did I eat? Now I'm really sleepy and I need to take a nap. So it can be a great way to just check in. So the way I'm going to set my timer so I don't go over the time. But if we can start, if you're going to join me for this, you don't have to, but I encourage you to sit in a comfy position, feet on the ground if you can, and then close your eyes and start focusing in on your breath. And then the sound of my voice. And so breathing in slowly, in through your nose if you can, out through your mouth. Breathing in slowly and out slowly. Again, we're trying to calm that brain, calm that heartbeat. And you do these breaths at your own pace, not necessarily the pace that I set when I say breathe in. If that's not on your breathe in, that's okay. And think of your breath as an anchor. So when your mind wanders, or you think of all the things that you have to do today or tomorrow, just come right back to that breath, breathing in and breathing out. Just a few more ins and outs slowly. In and out. And I think today we'll start with our feet. And so if you can bring your brain, your mind's eye down to your feet, kind of picture your toes, the bottoms of your feet, tops of your feet, even up to your ankles. And if you can do a little toe wiggle, if you can, you feel like it, and kind of pedal your feet a little bit, slowly though. Slowly up and down, reaching those toes towards the ceiling if you can. If you can't, just stick with your breath. Slow cycles. And then come back to neutral with your feet. And this is a way of checking in. How do my feet feel today? Tingling, numbness, sore feet. Maybe you've been on them for, all week. Maybe you're feeling really good, which is great. And then as you continue to breathe, on your inhale, move up your leg, picturing your calves, your shins. Come up to your knees. If you can, bend your leg a little bit, move your leg out, feel that knee. Make a muscle with your calves, your shins. Again, it's just checking in. How do I feel? What do I feel? On your next breath in, move up your leg to your thighs, and up into your hips. Our hips and thighs do so much work. They help us sit. They help us with stability, help us walk if we're walking, doing any physical activity, even bending down. So it's those hips, those thighs, all those big muscles. And those could be so important to our health and our well-being and just how we feel in general. So if you have the ability to do it, if you want to do it, just kind of wiggle in your seat. How do my hips feel today? Sometimes I have a dodgy hip, sometimes it doesn't do well. And so those are days that I have to do some more stretching in that particular hip. So just notice it. And then come back to your breath. Slow, deep breaths in and slow breaths out. Great job. We're going to come up into our belly. You can imagine your abdomen, and maybe with your breathing, you're getting a good belly breath. And that's where that breath comes in through your nose and mouth, goes down into your lungs, continues down into that diaphragm. And so that diaphragm is a balloon. And so your belly should rise with your inhale and fall back with your exhale. And that is a good belly breath. Think of all that oxygen getting all the way down into that diaphragm. So imagine that breath doing that cycle through your body, but also to check in with how is your belly, your abdomen doing today? Are you hungry? Are you thirsty? Did you have a great breakfast and this is putting you to sleep? Having any intestinal issues today? We're not feeling really well. Upset stomach. Because those are ways that you want to check in with your body and then address it. How do I feel? Is there something I can do to alleviate this? Is it something that I can keep track of or need to keep track of to share with one of my doctors? Something just to monitor for myself. So they're good questions, good ways to check in. And so we're going to come up into the lungs. And again, focus on that breath, the way that's coming in through your nose or mouth. Your lungs, those balloons, right? That expand with that good breath of air. And then shrink down as you push that air all the way out of your lungs. Focus on that cycle. Breath in, breath out. And you're bringing all that oxygen to every cell in your body. It's moving all over your body. And with those slow breaths, if you can, if you feel like it, putting your hand on your heart, just checking that heartbeat. Has it slowed down? Do you notice a change? Thinking about your brain. Is it slowing down? Is it still racing with things that you need to do or things you're thinking about? That's okay. Meditation doesn't have to be that nothing's in your head. Meditation is just having that thought, recognizing it. Yep, I need to go pay all those bills today. I need to pick so-and-so up from the airport. I've got to do laundry. But having the thought and then going, I'll do it in a few minutes. I'm just going to breathe and come back to your breath. That's meditation. It takes practice. So just breathe in, breathe out. Visualize your lower back moving up to the center part of your back. Can you feel the chair that you're sitting in? Can you feel your clothes on your skin? How's your back doing today? How's it feel? You feel strong? Do you feel uncomfortable, achy? Just take note and come back to your breath. And we're going to come up to your shoulders before we end. And if you feel like you can do it or want to do it, I invite you to roll your shoulders very slowly. Bring them up to your ears, bring them back against your chair, and down towards your hips, and then back up. Just do that 1 or 2 times, very slowly. Right up towards your ears, towards your back. Bring them down towards your hips. Come back to neutral. That's a great one for people that carry stress in their neck and their shoulders, or if you've slept wrong, been sitting at your computer or watching TV for too long. Those are big muscles that can get sore and get stuck. So just doing those shoulder rolls backwards and forwards can really help. But just checking in, how are your shoulders and neck doing today? How do you feel? Do you need to do more of those later? You feel pretty good? Just breathe in and out. Slow breaths. Another good thing about meditation is you can do it anywhere that you feel safe and that you could sit. If you can close your eyes in a safe space, that helps even more, because when we close our eyes, it takes away visual stimuli. So you can still hear things, but it just is another way to help that brain turn little pieces off, right? And just to rest, and to calm down. And that breath is calming the brain, calming the heart. And it's just giving you a few minutes. Again, don't have to have nothing going on in your head, but just have those thoughts and say, I'll do it in a minute. I'm going to take care of myself for a few minutes, which is really important. All right. As we finish, a few more slow, deep breaths. Deep breath in, deep breath out, slow breaths out. When you're ready, come open your eyes, come back into your space. That was very short. And I'll just give tips that you can do meditation by yourself. It doesn't have to be a guided one. It's just the breathing and just trying to calm down, calm the brain and calm the body. Online, YouTube, there are apps, there are videos. There are so many places that you can find different types of meditation. There's yoga meditation, there's just deep breathing meditation. There's guided meditation, like a body scan, which is what I did, or a guided meditation, say, on a walk in the woods, where you're kind of visualizing a walk up a mountain into the woods, and what do you hear and what do you see and what do you smell. So all of these exist online for free. Apps, many of them are free, that you can find ways to practice your meditation so that you, the more you do it, the better you get. And it really does work. It really, really can. And I encourage everybody everybody to try it and to do it at least once a day. So that is my time, I believe. And I'm so grateful to have been back and to spend time with you today. And have a great rest of your day, everybody.
Thank you, Kim. I know I needed that. And we're so happy to see you. We miss you. And we're all going to have to refrain from putting in the chat questions about your trips. So, all right. Now we have a talk from Dr. Petra Brayo and Dr. Amy Safadi. And they are going to be talking about viruses and MS. Dr. Safadi and Dr. Brayo are completing their neuroimmunology and multiple sclerosis fellowships at Georgetown. We love having them. They have been a wonderful addition to our team, and we're very excited to hear this timely talk. So I think Dr. Brayo will be speaking first.
Let me share my screen. Okay, so both me and Dr. Safadi will be talking about MS and viruses. I'll start with just kind of sharing, what is the relationship between multiple sclerosis and viruses? One of the questions that we get asked a lot when people get first diagnosed with MS is that what caused this? And to be honest, at this point, like the exact cause of MS is still a little bit unknown, but we have always suspected that viruses do play a role. And specifically, one virus in particular, the Epstein-Barr virus, in a recent study has shown to be playing a huge role in causing multiple sclerosis. We also know that besides viruses, there's a little bit an element of genetics predisposition. They play a role. So for example, it's not the whole role, but we know like somebody has an identical twin, they have a 1 in 4 chance of developing MS. So again, genetics play a role, but not the huge role. And then we have some CSF studies that were done, and these studies show that about 90 to 95% of patients with MS, when we test some proteins in their spinal fluid, these proteins that have a connection to be part of the reaction to viruses have been shown there. So we think, again, virus is probably part of the trigger that ends up eventually causing MS. So how do we know that a virus in particular can be a trigger for MS? There are kind of two requirements that we need to have. The first one is that the virus needs to be in the body before MS develops. So it can be a virus that, somebody develops later, but we have to be exposed to that virus first before we are able to make the diagnosis to see that this is a connection or a trigger. And then we need to know that the virus actually causes the disease and it's not just happening alongside the disease. So that's kind of the second requirement, that is just not a coincidence that somebody, had this viral infection and ended up developing MS down the line. We need to show something, strong proof that tells us, okay, that was the cause, not just something coincidentally happening at the same time. So like I mentioned, the one virus that has been associated to have this strongest connection with MS is the Epstein-Barr virus, EBV. So what is EBV? EBV is part of the herpes family of viruses. There's a whole lot of them. I think herpes simplex is the one that causes cold sores and genital herpes, but also within the same family, there is the herpes zoster virus. That's the one that causes chickenpox and shingles. There's a whole family of them, but typically EBV is one of those viruses within that family that often causes no symptoms. So a lot of people have actually been exposed to it. They just don't know it because they don't develop symptoms. The biggest symptom, or the biggest case that we often associated with EBV when it causes symptoms is that when it causes mono or infectious mononucleosis. A lot of the times we are exposed to that virus and it just stays in a latent state inside the body. It really does not do much. Every once in a while, it can reactivate by causing some of the symptoms, like kind of like the mono-like symptoms or cold-like symptoms. But most of the time, it's just kind of staying there in the body latently, like not doing anything. And like I said, almost pretty much every one of us, and specifically, since this is a group that has a lot of MS patients, have been exposed to it. But really, even people who do not have MS, when they do population studies, about 95% of the adult population in the world have really been exposed to EBV at some point. But the trick here is that not everyone goes on to develop MS. So I think kind of the biggest thing to think about is like what happens in particularly in patients with MS that kind of having that Epstein-Barr virus causes them to develop MS down the line. I just want to go over kind of some of the evidence between EBV and MS. So the biggest study that showed us this was a study done by Dr. Alberto Acherio from the Harvard School of Public Health and his team. And this study focused on active duty US military personnel between 1993 and 2013. So over this 20-year period. Where they looked at about 10 million active duty personnel. It's neat because in the military, when people first get recruited and kind of during their active service time, they're required to give blood samples for different screenings. These are taken every 2 years as just part of a routine medical screen. And then the neat thing again about them is that they save these blood samples later, just in case they want to go back and determine anything. So in this study, they used that huge resource that we have. And then one of the things that they looked at in these 10 million active duty personnel is that when were these people infected with the Epstein-Barr virus? And then they were able to see that samples from 801 individual who developed MS were tested specifically. And then they compared those to 1,500 match controls. So people around the same age, the same gender, things like that, like same growing up environment, things like that to just who did not have MS. And they compared both of them. And they noticed that in the people who went on to develop MS, they had a much higher rate of EBV infection among those people compared to the controls. And pretty much out of that 801 individuals, there's actually only one single person who tested negative for the Epstein-Barr virus. So it showed that overall, people who were infected with EBV are 32 times more likely to develop MS than people who just were never exposed to the virus. So what about this one person, like we said, 801 but there's this one person who did not get exposed to EBV. That tells us that maybe there's an association with other viruses that behaves the same. We just don't know really. And that's kind of like the part that we need to figure out. The researchers just wanted to make sure in this study that it is not any of the other viruses. And they really did not find any association between MS and any of those other viruses, including CMV, which is cytomegalovirus. It's a virus that's very similar to EBV, actually can also cause mono and behave similarly, but we really did not find the connection with that. But there are other research teams besides this big study. So for example, there's another team in Spain that found that there is a connection between HHV6, which is the human herpes virus 6, again, within that herpes virus families. And they found that antibodies reached their highest levels for that virus in people with MS about 2 weeks before relapse occurred. So there's could possibly be connection between MS and HHV6 and being exposed to it. So really, there's a lot of research kind of ongoing to figure out if there's more to the story behind MS and viruses. So really kind of, is it all about EBV? Like, is this the only requirement? And really the conclusion from this study is that EBV is an important part of the chain of events that leads to most cases of MS. I think of it as, it is kind of like the first trigger, you need to have EBV mostly, could be another virus to end up causing MS. But I think what we're understanding is there's a whole other mix in there, kind of like having the genetic predisposition or being in certain environments. We know that there's an association with maybe vitamin D levels if they're lower, or if people who live a little bit northern from the equator. So there's a lot of other environmental and genetic factors, but at least for now, we think that this chain of events has EBV as an integral part of it, but it's not just sufficient to trigger MS. It's not the only trigger there. So we need to really learn about some of these other factors and what role do they play in this whole kind of, I don't know, chain of events, I guess. So what is next? I think this is kind of exciting news because first of all, if we know that the Epstein-Barr virus is part of this, if we are able to develop vaccinations against EBV, that can potentially something that would prevent developing MS in the future. And we've known that viruses, for example, have a huge role in triggering certain diseases, and vaccination campaigns can prevent that. For example, the HPV, the human papilloma virus, and vaccinating children were they young against it, that actually leads to preventing cervical cancer. So it's kind of the same idea. If we vaccinate children really early on against EBV, knowing that everybody gets exposed to that at some point, that can be one of those things that kind of prevent MS from developing in the future. But for the people who have already been exposed to EBV and already have developed MS, we can potentially look at some antiviral medications against EBV. And was the idea that, yes, you've been exposed to it, but if we give you those antiviral medications, it's able to keep the EBV virus in this latent, like quiet stage, and that can prevent this possibly MS onset and even like future relapses. But overall, we just need to have more research to learn more about EBV and other causes of MS. Like, is the virus itself that's causing the problem, or is it how the body reacts to the virus that causes the problem and changes how the immune system responds and kind of does that self-attacks that cause MS? The other thing that we need to think about is that, again, kind of what I was mentioning, like what environmental or genetic factors are playing a role and how does that factor in with EBV? So I hope that was helpful. I will be taking questions or answering them at the end. And for that, I will hand it over to my colleague, Dr. Safadi, who is going to talk to us about MS and the relationship with the virus that's been on everybody's mind for the last few years, which is the COVID-19 virus.
Thank you so much, Dr. Breyer. That was great. I'm just going to share my screen now. All right, so the virus that's really at the forefront of everyone's mind is COVID. And so with this case, this is more of like a practical kind of situation in how patients with MS can deal with COVID during this time in terms of vaccines, updates, timing, and also Evishield as well. So just so everyone's clear, having MS does not make you more likely to get COVID-19, but there are certain risk factors that can predispose you to having greater risk after getting an infection with COVID-19. And this is honestly the same risk that anyone would have, even if they didn't have MS: older age, comorbidities, obesity, diabetes, high blood pressure, heart disease. If you're already taking steroid medications, certain disease modifying therapies can lead to greater risk, and we'll get more into that as well. But it's good to know that now there are vaccines available, and they do reduce risk of getting severe illness from COVID-19 infection. So a lot of the questions center on, is the COVID-19 vaccine safe? And the answer is yes, it is safe, and it is beneficial. The benefits of getting vaccinated against COVID far outrisk any potential risks to the vaccine, especially if you fall into a high risk category. For example, if you're of an older age group, or if you have other comorbid conditions that can make you more likely to have severe COVID-19 infection that would land you in the hospital. The COVID-19 vaccines are not likely to make your MS worse. It will not likely trigger an MS relapse, and it's safe to use in patients with MS. There's actually a study that came out fairly recently looking at COVID vaccination reactogenicity in patients with MS. And they found that overall, the safety data is quite reassuring. in terms of reactions to the vaccine, which seem to be on par with what general population patients experience who don't have MS. Usually pain at the injection site, fatigue, headache, malaise, very similar to the general population. A lot of the patients here were on a variety of different disease-modifying therapies. Some weren't on any disease-modifying therapies. And when they were running the statistics, they did interestingly know that those on certain disease-modifying therapies like fingolimod or natalizumab were less likely to have a reaction after the first shot. But overall, the safety data was quite reassuring. So then what are the special considerations when getting the COVID-19 vaccination? So first, if you had COVID, like the infection itself, or you tested positive for COVID-19, you're already developing antibodies against COVID, and you may not need the vaccine dose for another 3 months since when your symptoms started. And this is per the CDC guidelines. So the question is, when should I get my vaccine? I just had the COVID infection, probably about 3 months from the time of your infection. There is a general rule of thumb. If you have MS and you're on disease-modifying therapy, you should not stop or pause your MS treatment for the vaccine. If you're not starting therapy yet, or if you're about to start, the recommendation is to get fully vaccinated 2 to 4 weeks before starting treatment, and this can vary with the treatment. For example, for ocrelizumab on the Ocrevus prescribing information, they recommend that if you had an inactivated vaccine, which is what the COVID-19 vaccines are, to get it about 2 weeks before starting treatment. And usually this works out well because it takes time for prior authorizations to even get the medications through and get it into your hand. So during that time, it's a good time, if you haven't already, to get vaccinated with either the primary series, if you haven't already, or the booster vaccine. So there are some special considerations with disease-modifying therapies, like what I alluded to earlier. There are certain medications that can make the humoral response to a vaccine less adequate than if you were someone who was not on this disease-modifying therapy. So for example, if you are on an S1P receptor modulator, such as Gilenya or fingolimod, Mayzent, siponimod, Zeposia, Ponvory, it can make it so that your response to the vaccine is a little bit less robust. Similarly, B-cell depleting agents like Ocrevus, Kesimpta, those are really popular ones. There are also evidence that it can lead to a less robust response to vaccines, and we'll talk about how we can manage that. But in terms of timing your vaccine around these medications, if you are on any drugs other than what's listed here on this PowerPoint slide, you don't have to change anything. You just take it as is. Even the S1P receptor modulators like Gilenya, Mayzent, Zeposia, Ponvory, you do not stop your medication treatment at all. You just get the vaccine and continue to take your daily medication doses. If you are on Ocrevus, where it's given once every 6 months, there is not like really robust studies around this, but the general expert consensus is to try to time your vaccine in between doses. So for example, about 3 months after your last Ocrevus infusion dose, and about in between your doses. With Kesimpta, since it's given once every 4 weeks, once a month, you would probably do it in between the 2 doses, like 2 weeks after your last Kesimpta dose. With these medications, the idea is if you can get the COVID vaccine, like about 3 months, like in between doses, you'll also give your body enough time to mount an immune response before your next dose is due. And usually that can be anywhere from 2 to 4 weeks. But again, there's not really clear, robust data to guide this. And some studies have suggested maybe there is some response to the COVID vaccine, maybe it's better than nothing kind of situation. So if timing really doesn't work out, it's still better to get the vaccine, even while you're on these medications. Lemtrada or alemtuzumab, some of the guidelines, again, it's not super robust data, would be to consider getting vaccinated about 6 months or more after the last Lemtrada dose. But again, this can all be individualized according to your certain situation within talking to your provider. So what about other vaccines? It is safe to get like the flu shot with your COVID vaccine shot per the CDC. Sometimes you might get a little bit more of a side effect like reaction with pain, malaise, like injection site pain. So it's also okay to stagger it. When you're on a disease modifying therapy, you would prefer non-live or inactivated vaccines. And some of the common vaccines that you can get that are all inactivated, other than the flu shot, are the Shingrix shot for shingles or pneumococcal vaccines. And again, similar guidelines apply and when to get them in terms of timing with your medications if you happen to be on a B-cell depleting agent. But if you're on any of the other medications, once daily pills, that kind of thing, you do not stop those therapies for this. So then the question is, well, what if I'm on one of those medications like the B-cell agents, Ocrevus, Kesimpta, Gilenya, Siponimod, those types of medications that can make it so that I don't have as a robust a response to vaccines. And this is where Evusheld has been really helpful. So Evusheld was given emergency use authorization December 2021 by the FDA, and it's basically long-acting monoclonal antibodies, a combination of two of them, that's used as pre-exposure prophylaxis to prevent COVID-19. That is the theory behind it. And it's been it's been shown to be safe, it's been shown to work well, and it's very reasonable for patients who are on the disease-modifying therapies like what is shown on the list. The S1P receptor modulators, the B-cell depleting agents, Trata. You still get the COVID vaccine, even if you get Evusheld, unless there's contraindications around that. If you do get the COVID vaccine, you would wait 2 weeks after before getting Evusheld. And Evusheld is usually dosed once every 6 months. So given the timing of when it came out, I see a lot of patients who are already getting or about to get their second dose of Evusheld. Evusheld is quite effective. There was a very recent study that came out, a small sample size, but patients on B-cell depleting agents like ocrelizumab, Ocrevus, or ofatumumab, Kesimpta, that have had 100% antibody response measured 2 weeks after receiving Evusheld. There's no special timing of when to get Evusheld when you are on these disease-modifying therapies. But there was a recent news article that came out. Maybe Evusheld is less effective against the latest subvariant, BA.4.6. The dominant variant, though, is BA.5, and Evusheld is perhaps effective, against, potentially that. So it's still recommended to get it. Of course, the new bivalent COVID booster is effective against BA.5 and BA.4. So highly recommend you get that booster if you haven't already. Thank you. We can take questions at the end of the Q&A session.
Thank you. That was great information. Very helpful during this time. Okay, so we are going to take a break now. And again, we will have some wonderful sponsor spotlights here in the webinar, and you can also exit out into the virtual exhibit hall to see some of the sponsored pages. And we'll meet back here at 11:30 for our next presentation.
MS tries to stop me.
MS is like riding into headwinds, but I keep pushing forward.
Does MS define me? No, it does not.
I take Ocrevus, an infusion treatment that's 2 times a year.
A prescription for adults with relapsing or primary progressive forms of multiple sclerosis, Ocrevus is proven effective in reducing relapses in RMS and slowing disability progression and reducing brain lesions in RMS and PPMS.
Don't take Ocrevus if you've had a life-threatening allergic reaction to it or have Hep B. Tell your doctor about vaccinations or if you've had colitis or Hep B, as Hep B could come back. A common side effect of Ocrevus is infusion reactions. Some may be serious and require hospitalization. It can increase your risk of infections, which can be serious and may decrease some immunoglobulins. PML is rare but may happen with Ocrevus. It can lead to disability or death. An increased risk of colitis and cancer, including breast cancer, may exist.
We take Ocrevus. That's more progress, less progression.
Ask your doctor about starting with 2 times a year Ocrevus. What is Ocrevus? Ocrevus is a prescription medicine used to treat relapsing forms of multiple sclerosis, MS, to include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease in adults. Primary progressive MS in adults. It is not known if Ocrevus is safe and effective in children. Who should not receive Ocrevus? Do not receive Ocrevus if you have an active hepatitis B virus, HBV, infection. Do not receive Ocrevus if you have had a life-threatening allergic reaction to Ocrevus. Tell your healthcare provider if you have had an allergic reaction to Ocrevus or any of its ingredients in the past. What is the most important information I should know about Ocrevus? Ocrevus can cause serious side effects, including infusion reactions. Infusion reactions are a common side effect of Ocrevus, which can be serious and may require you to be hospitalized. You will be monitored during your infusion and for at least 1 hour after each infusion of Ocrevus for signs and symptoms of an infusion reaction. Tell your healthcare provider or nurse if you get any of these symptoms: itchy skin, rash, hives, tiredness, coughing or wheezing, trouble breathing, throat irritation or pain, feeling faint, fever, redness on your face, flushing, nausea, headache, swelling of the throat, dizziness, shortness of breath, fatigue, fast heartbeat. These infusion reactions can happen for up to 24 hours after your infusion. It is important that you call your healthcare provider right away if you get any of the signs or symptoms listed above after each infusion. If you get infusion reactions, your healthcare provider may need to stop or slow down the rate of your infusion. Infection. Ocrevus increases your risk of getting upper respiratory tract infections, lower respiratory tract infections, skin infections, and herpes infections. Infections are a common side effect which can be serious. Tell your healthcare provider if you have an infection or have any of the following signs of infection, including fever, chills, or a cough that does not go away. Signs of herpes include cold sores, shingles, genital sores, skin rash, pain, and itching. Signs of more serious herpes infection include changes in vision, eye redness or eye pain, severe or persistent headache, stiff neck, and confusion. Signs of infection can happen during treatment or after you have received your last dose of Ocrevus. Tell your healthcare provider right away if you have an infection. Your healthcare provider should delay your treatment with Ocrevus until your infection is gone. Hepatitis B virus, HBV reactivation. Before starting treatment with Ocrevus, your healthcare provider will do blood tests to check for hepatitis B viral infection. If you have ever had hepatitis B virus infection, the hepatitis B virus may become active again during or after treatment with Ocrevus. Hepatitis B virus becoming active again, called reactivation, may cause serious liver problems, including liver failure or death. Your healthcare provider will monitor you if you are at risk for hepatitis B virus reactivation during treatment and after you stop receiving Ocrevus. Weakened immune system. Ocrevus, taken before or after other medicines that weaken the immune system, could increase your risk of getting infections. Progressive multifocal leukoencephalopathy, PML. PML is a rare brain infection that usually leads to death or severe disability and has been reported with Ocrevus. Symptoms of PML get worse over days to weeks. It is important that you call your healthcare provider right away if you have any new or worsening neurologic signs or symptoms that have lasted several days, including problems with thinking, eyesight, strength, balance, weakness on one side of your body, using your arms or legs. Decreased immunoglobulins. Ocrevus may cause a decrease in some types of immunoglobulins. Your healthcare provider will do blood tests to check your blood immunoglobulin levels. Before receiving Ocrevus, tell your healthcare provider about all of your medical conditions, including if you have ever taken, take, or plan to take medicines that affect your immune system or other treatments for MS, have ever had hepatitis B or are a carrier of the hepatitis B virus, have a history of inflammatory bowel disease or colitis, have had a recent vaccination or are scheduled to receive any vaccinations. You should receive any required live or live attenuated vaccines at least 4 weeks before you start treatment with Ocrevus. You should not receive live or live attenuated vaccines while you are being treated with Ocrevus and until your healthcare provider tells you that your immune system is no longer weakened. When possible, you should receive any non-live vaccines at least 2 weeks before you start treatment with Ocrevus. If you would like to receive any non-live inactivated vaccines, including the seasonal flu vaccine, while you are being treated with Ocrevus, talk to your healthcare provider. If you have a baby and you received Ocrevus during your pregnancy, it is important to tell your baby's healthcare provider about receiving Ocrevus so they can decide when your baby should be vaccinated. Are pregnant, think that you might be pregnant or plan to become pregnant. It is not known if Ocrevus will harm your unborn baby. You should use birth control, contraception during treatment with Ocrevus and for 6 months after your last infusion of Ocrevus. Talk with your healthcare provider about what birth control method is right for you during this time. Pregnancy registry. There is a pregnancy registry for women who take Ocrevus during pregnancy. If you become pregnant while receiving Ocrevus, tell your healthcare provider right away. Talk to your healthcare provider about registering with the Ocrevus Pregnancy Registry. The purpose of this registry is to collect information about your health and your baby's health. Your healthcare provider can enroll you in this registry by calling 1-833-872-4370 or visiting ocrevuspregnancyregistry.com. Are breastfeeding or plan to breastfeed? It is not known if Ocrevus passes into your breast milk. Talk to your healthcare provider about the best way to feed your baby if you take Ocrevus. Tell your healthcare provider about all the medicines you take, including prescription and over-the-counter medicines, vitamins, and herbal supplements. What are the possible side effects of Ocrevus? Ocrevus may cause serious side effects, including risk of cancers, malignancies, including breast cancer. Follow your healthcare provider's instructions about standard screening guidelines for breast cancer. Inflammation of the colon or colitis. Tell your healthcare provider if you have any symptoms of colitis, such as diarrhea, loose stools, or more frequent bowel movements than usual, stools that are black, tarry, sticky, or have blood or mucus, severe stomach area, abdomen, pain, or tenderness. These are not all the possible side effects of Ocrevus. Call your doctor for medical advice about side effects. You may report side effects to FDA at 1-800-FDA-1088. You may also report side effects to Genentech at 888-835-2555. For more information, go to ocrevus.com or call 1-844-627-3887. For additional safety information, please see the full prescribing information.
Okay, and we have an additional spotlight for everyone to view until we meet again at 11:30. Just a reminder, you can also visit our sponsor pages in the virtual exhibit hall. And we'll start again in about 5 minutes. Okay, so it is 11:30. So we can get started again. Before we moved on, though, I did want to let everyone know Kim put some resources in the chat, so please check that out. But our next speaker is Dr. Manrique, who is also completing his neuroimmunology and MS fellowship at Georgetown. He also received a fellowship award from EMD Serono to focus on reducing disparities in neurologic care for MS patients. Today, he's going to be talking about MS in the Latin Hispanic population. So I will stop sharing my screen.
Thank you.
Take it away.
Can you hear me okay?
Yes, we hear you great. Thank you.
All right. And now, can you see my slides? Okay. Are you able to see my slides?
Yep.
Okay. Thank you. So first of all, thank you, Bethany and David, for organizing this great education day. I am here to talk about MS in the Hispanic Latinx population, but the background really is that we're going to touch a very important topic for the comprehensive care of the patients. I want to thank all the patients who are here joining us. We really appreciate you being here. But the background topic here is really MS healthcare disparities, and actually the main issue that we have been seeing in MS and many other illnesses and conditions is that there are certain so-called predisposition or groups of individuals who have worse health outcomes, and we're trying to figure out why does that happen. In terms of MS, in the past, in the old days, we used to think that MS was a condition that affected mainly white female patients, and it turns out that actually Black patients can have the same, or in some literature, even higher prevalence and rates of MS. And then it comes to a question of why did we think for so long that it was that way when that was not really the reality? And actually, a similar thing that we're going to discuss today is happening with the Latinx Hispanic individuals. We think that the prevalence is lower than other groups, and we're going to discuss why that could be in this presentation. And then we're going to talk about what happens in terms of diagnosis and diagnostic process, the MS severity, morbidity, and the last part will be about their perceptions of illness as well. So as Bethany mentioned, we are the first of its kind neurodisparity fellowship at Georgetown, and we are so happy to be able to help our patients in that way, doing research in healthcare disparities. But we're going to start talking about race and ethnicity definition. Those are sociopolitical constructs that were driven by historical circumstances, but continue to disadvantage some minorities, such as Black and Hispanic Latinx individuals. And then the characteristics of MS in these individuals are so heterogeneous that there is more and more research interest in this, in studying why do they behave so different. And this is an MS World Atlas, and around 2.8 million people worldwide and I think this data is from 2013, so it's a little bit older, but are affected by MS. And I just wanted to show the world map because there is clearly a tendency for the northern and the southern regions of the world, so people who live far from the equator, to develop MS. And there are different theories about it that have been already mentioned today, and there is also a reminder for us to think about how, when we say that an individual is Latinx or Hispanic, so it's usually people who are born in the regions that were colonized by Spain and Portugal. I think that is important to include Brazil there, and then Latino or Latina refers to people who have ancestry and cultural ties to Latin America. So there is there are a couple of important things before we talk about prevalence of MS in these individuals. So the first one is that there is a higher prevalence of MS in Latinx Hispanic individuals that live in the US compared to Latin America. And this might be because they are exposed to different environmental factors, and also, but also we need to think that the prevalence in Latin America might be underestimated because there is not as much accessibility to a specialist and neuroimaging over there. So the other thing that we have noticed recently, and when I say recently, might be the last 15 to 20 years, is that more, as I already mentioned, Black patients and Hispanics are being diagnosed, and then there is very, very strong evidence that Black patients develop that previously were believed to have a low MS, to be a low MS risk population, and now there is evidence showing that they actually have same or higher prevalence and incidence of MS. So now we're going to talk finally about what does the literature says about Latinx and Hispanic individuals. Before we talk about that, actually, I'm very happy that Victoria Reese is going to be talking next, because she is part of the African American MS registry. And actually, she's a huge advocate for MS health disparities, as she's going to talk. But the latest study that we have about prevalence is in Southern California. And actually, here you can see how prevalent is MS in patients from Kaiser Permanente over there. And then you see how, the total number of patients with a prevalence of 234.8 per in the whole population, as compared to the Black individuals that were 233.2. So very similar prevalences over there. And when you see the green bar here, the Hispanic prevalence is only 66.2. And then when you compare females versus males, kind of like the similar pattern you see. So what this means is that MS is approximately 3 times less prevalent in Hispanic Latinx individuals, what this data is showing in Southern California. And this goes along with many of the other reports and papers that have been published, showing that in general, Hispanic Latinx individuals and actually Asian individuals have less prevalence of MS, and this is very relevant for us, because then our next question will be, what is that is preventing them, or what is that protective factor that Latinx Hispanic individuals have that allows them to be immune to MS, so to speak, right? So what's going on there? So when you go deeper into this paper, in the methods, they say that they used the electronic medical record as a surrogate for for race and ethnicity information. And the way that the US Census Bureau determines this race and ethnicity is that they actually ask the individual, how do you identify? So it's a self-identified information in the US Census Bureau, whereas our epidemiological studies in the medical community are using the electronic medical record. Now you will say, all right, well, that might be a good surrogate. But actually, we have found actually in our center that it's not. Our initial research is showing that actually only 1 out of 4 patients who are Hispanic or Latinx individual are correctly classified. And when we went further to find out why, we realized that oftentimes these patients are not asked what's their race and ethnicity. They are classified as white, unknown, or other, and then I feel like this might not be unique to the Georgetown, to the MS and Neuroimmunology Georgetown Center. Probably this is happening worldwide, to be honest, or at least in the USA, where race and ethnicity is such an important topic in terms of healthcare disparities. So the bottom line here is that probably this prevalence is being underestimated. How underestimated? We don't know really. We might need to reframe all of these epidemiological studies and make sure that the patients are asked what's their race and ethnicity. And then within the same ethnic group, Hispanic/Latinx, we find a huge amount of diversity. They can have different ancestry and genetics, environmental exposures, and different socioeconomic factors. And actually, in this paper published in 2022, they show what are the differences between Hispanic Latinx individuals in terms of ancestry. So stands for University of Miami, and PR Puerto Rico, and then this is University of Southern California. So you see in the blue color is the African ancestry, the green color is the Native American, and then the red color is European. So in the University of Miami, there is a huge component of European ancestry, as opposed to Puerto Rico, where there is a higher proportion of African ancestry compared to University of Miami. And then in Southern California, with Mexican and Central American migration, then you can see the green area growing larger. So just to show how these socio-political constructs are not talking really about the ancestry or genetic. They are so diverse within the same group of individuals. And there are environmental differences that actually change depending on whether these patients have been born in the US or somewhere else. The number one is vitamin D and sun exposure. And actually the age of immigration is a huge component of this as well. And there are different studies showing that patients that have migrated to the US before their 20s have a higher risk of developing MS than patients that migrate after their 20s. And then there are other environmental factors such as parasites in LATAM that may have a protective effect because they could suppress the development of MS. And then the gut microbiome that is different in patients who are immigrants. And then finally, the socioeconomic factors. These are the social determinants of health, very, very complex in terms of our reality. And then just to mention them broadly, economic stability, the education, their social and community context, neighborhood and healthcare access are very, very relevant to how they can be diagnosed. And that's what the next slide is about. And just to mention briefly, this study show how patients who are Hispanic white compared to non-Hispanic whites are actually that they have symptoms at a younger age, and then they're diagnosed around the same age. However, their age at the first exam is usually younger. So why does that happen? We believe it's because patients who are Hispanic that were born in the US have a younger onset of MS, and when they are compared with the immigrants. However, the downside is that the immigrants having an onset at older ages, they could have a higher risk of developing progressive MS subtypes, as we know very well that when you have an onset closer to 40 years old of MS, these patients have higher risk of going into a progressive form of the disease. Actually, the MS severity, there is more and more growing literature showing how patients who immigrated at a later age to the US are twice as likely to have ambulatory disabilities compared to their counterparts that were born in the US. And then the differences in social, environmental, and cultural factors probably are affecting how they can access to how they can get access to the healthcare. And this is really striking. The patients who are Black or Hispanic Latinx, they die more due to MS than their white counterparts. And then also these patients have, in general terms, more comorbidities than other ethnic groups. So we need to do more work. And then treatment initiation actually is usually the North American Registry for Care and Research have shown that patients who are Hispanics or Latinx are less likely to be treated with a DMT for different reasons that probably we still need to elucidate. And this is actually very striking. Only 7.6% of participants in clinical trials are Hispanic Latinx, so it's very underrepresented despite almost representing 20% of the US population. So there is a clear disparity here. And many of us, we are saying just because we're justifying this just because they have less prevalence of MS. Well, I mean, we couldn't conclude that definitely based on what I just told you and the issues that we have with these studies. And why all of this is happening, right? Why they're not being as diagnosed as other ethnic groups? Why do they have more severity and worse health outcomes? And why do they die more? We believe that it has to be a lot with perceptions of illness, other than all the complex socioeconomic issues that they could have and barriers. And actually, this paper in 2017, they asked them a simple question, that if there were any significant events that they would like to report led to the MS onset, and their answer was classified in terms of if they had perceptions that were environmental, sociocultural, and biological. And environmental, like the weather, infection, diet, stress; sociocultural, like fright, anger. And many of these words were actually answered in Spanish that don't have an exact translation. So there is a language barrier as well. But what they found out is that there are profound emotional perceptions that are more prevalent in patients that are immigrants when they are compared to US born, here in the blue bar compared to the gray bar. And then these social, cultural, or emotional perceptions could be affecting or increasing the likelihood of future disability and symptoms in chronic medical conditions such as MS. There is need for a multi-level approach to these disparities, and we need to work more on that. So that's part of the reason why we are working in this project, trying to address these issues in our patients, and we are going to try to ask them about their perceptions of illness. Here are a few of the conclusions, the most important points of the talk. We need to figure out first if MS is really 3 times less prevalent in Hispanic Latinx individuals, kind of questionable at this point. And then we need to think about their severity and mortality, and try to figure out why the perceptions of illness they have regarding MS are so different. And I would like to conclude here, and I'm open to take any questions. Thank you.
Thank you. We're going to do the question and answer at the end if you have time to stay. Is that okay?
Yes, that's okay.
Okay, thank you so much. So finally, we have a very special presentation for all of you. We're very excited that Victoria Reese, the co-founder and CEO of We Are Ill, could join us today. She's been featured in Black Enterprise magazine, and she has received national recognition for her multiple sclerosis campaign, We Are Illmatic. She is a very sought after speaker, so this is a very special opportunity for all of us, including me, to hear her speak. So I'm very excited. Victoria, I'll let you share your screen and take over.
Sure, give me just 1 second. It's hard to follow introductions like that. Very sought after. That's nice. Okay. Are you able to share your screen? Because it's not, oh, actually I found it.
Okay.
I found it. All right. So my talk or my presentation is called Navigating the Healthcare System as an African-American Patient. I try to share my story as much as I can. I know that I'm not alone. I know that my story is unique to me, but also some of the challenges are not unique to underserved communities. So I'm really happy to be here. I'm always grateful to share my story and grateful for those who listen. So I'll take you on a journey with me. The year was 2012, and in January, I moved to Los Angeles, California. May 2012, I turned 25, and I was living my very best 25-year-old life. July 2012, I began experiencing numbness in my legs over the course of several months. September 2012, I was diagnosed with MS. So this is actual footage of me trying to get in my car. There were times, actually, this isn't me at all. This is Leonardo DiCaprio from a screenshot from Wolf of Wall Street. I use this to show, in a funny way, how challenging it was for me at times to just get in my car. So at times it got so bad that I would sit in stairways until someone could help me, or I would literally crawl to my car because of the numbness and tingling in my legs. So after some time, when I realized my legs were not just falling asleep often, I did visit my primary care physician to tell him what I was experiencing. He had an MRI done on my legs because that is exactly where the issues were happening. The results came back clear and normal. This guy thought I was crazy. My primary care physician asked me what kind of work I did. At the time, I was an aspiring talent agent. I was working at a Hollywood talent agency. It was very fast paced. I was admittedly under a lot of stress. He was confident that my symptoms were due to stress and stress alone, although I was confident that it had to be more. I've been stressed in my day, and I knew that this was different. So he prescribed me antidepressants. I moved on with my life, trying to figure out how not to stress. A few weeks later, I experienced an excruciating migraine that lasted over 10 hours. I didn't normally get headaches or migraines, so this was really bizarre. That very next morning, I woke up with numbness and tingling on the left side of my face, from my scalp to my chin. I was certain I then had a stroke. It wasn't a stroke. I went back to that doctor and he ordered me another MRI, but this time on my brain and spine. That MRI came back showing 9 lesions on my brain. He was now confident that this was relapsing MS. He went to the computer in his office. He printed out a description of what MS was, gave me that piece of paper, and I left that doctor's office a different person. Shortly after, I was officially diagnosed with relapsing remitting MS. Racial bias in pain assessment and treatment recommendations happen every day, but that's another conversation for another day. As a Black woman, I can't talk about this journey without mentioning access. That how even me, a college educated 20-something at the time, who owned a working laptop, a cell phone, and had access to Wi-Fi, couldn't even get medication at one point in time in my life. There was a time that I was an uninsured, inspiring entrepreneur, and I went about 6 months without medication. I had to fight. I couldn't help but to think of my Black brothers and sisters or anyone else from an underserved community that didn't have that same privilege that I had, how they were navigating all of this. If I couldn't get medicine and I had all that, I can't imagine everyone else. So finding community was super important, right? Seeking support wasn't an innate next step for me. I'm a Black girl born and raised in Detroit, Michigan by a single Black mother. We don't do therapy. We don't do support groups. We don't do national societies or anything else that says we actually need help. I know, though, that historically, people of color or people from underserved communities weren't always knowledgeable or had access to resources like that. So sometimes it can be really hard to make that connection. So naturally, like a true millennial, and at this point, I think I'm a geriatric millennial. Like a true millennial, I went to the internet. I depended on it for dear life to educate me on my new normal. I was Googling and I was Instagram searching MS, Black women with MS. And taking it a step further, like a true millennial, I actually used it as my digital diary. I went to social media to express myself. And this is the post that I announced to the world or to my world on Instagram that I had MS. So as I navigated my healthcare journey, it's imperative that I talk about my healthcare team or what I consider my healthcare team. And it's not just my neurologist. We all work together as partners in my healthcare journey, and they understand that I'm not only informed about my health, but I'm an advocate for it. So for me, my healthcare team is my neurologist, my MS specialist, who is an MS specialist, my partner, my primary care physician, my fitness trainer, and my therapist. That can be different for other patients. I choose my doctors carefully, and I aim to select doctors that prioritize quality customer service. Because of this, we've built a rapport where I see them as people and not just doctors, and vice versa. They're treating the person and not just the illness. They're treating Victoria, and I'm unique. I want this to be true for all people living with MS, no matter what race, gender, or age. Building community. So with my journey, like I mentioned, I was diagnosed in 2012. I started an awareness campaign called #WeAreIllmatic in 2017. That hashtag and that awareness campaign developed and morphed and blossomed into what is now a nonprofit organization called We Are Ill. We Are Ill is an official patient advocacy organization that was launched in 2020 with a vision to redefine what sick looks like for Black identifying women living with MS. Our goal is to be a fearless community, and to create culturally competent educational materials. By facilitating more robust discussions on the experiences of Black women living with MS, We Are Ill is changing the narrative of MS to not only improve the overall health outcomes of Black women, but also to eradicate this disease altogether. That's a picture of me and a few other women that are in our community. We all have MS. That logo there, I sketched it myself. Oops. All right, so meeting the community. As mentioned, this hashtag We Are Illmatic started in 2017. We kicked off an online support group on Facebook. Now we have well over 1,500 Black women all living with MS across the world. That little old awareness campaign that then turned into a Facebook group, that then turned into an official nonprofit organization, finally got to meet each other for the first time just last week at our first in-person event called Wellness Weekend in Atlanta, Georgia. I shared this because community matters, but we finally got to meet each other after a pandemic and everything else. This is an image of me speaking on stage in front of those women. And it was a hit. It was beautiful. We gathered about 100 Black women in real time. Black women with MS in real time. So I couldn't talk about this without talking about what health equity means to me and how that's a destination in the work that I do. I talked about this being my journey, so this is the goal here. I think a lot of people, when they describe health equity or when they think of it off top without really defining it, they may think or confuse health equity with equality. So I like to show this image or this graphic here in presentations or in any talks I'm a part of to really give a visual representation, because I'm visual as well, of the difference between the two. As you can see here, equality would be everyone getting a boost here, a stool or a box to step on. And it just makes us the same that we were when we were on ground. But equity means that there's an empathetic approach to understanding that we all don't start from the same point. So we need different levels of these boxes or crates or whatever that brown thing is there. We start at different points. So we all need different resources to be able to get the same equal quality care. So I just wanted to show that and let us sit with that for a moment so we truly can take home the visual representation of equity versus equality. All right. And lastly, before I leave, I like to end with this quote. The most disrespected person in America is the Black woman. The most unprotected person in America is the Black woman. The most neglected person in America is the Black woman. And that's a quote from Malcolm X. And I use that because while I believe he said that in a speech during the 1960s, don't quote me, that some of that is still prevalent today. It may not be in the same exact ways, and change has absolutely happened and progress has absolutely happened. But Black women die in the hospital and due to healthcare things all the time for multiple reasons that may not even have to do with MS. But there's a problem and it's an epidemic, and I'm fighting for a change in that. So please help me in my mission to change that. Thank you so much for having me.
Thank you so much. Thank you for sharing that with us. I think that was very helpful for everyone here, including the providers who are listening today. So thank you, Victoria. Okay, so I will share my screen. And so first of all, thanks everyone so much for being with us this morning. And if you can stick around, now is the question and answer portion of the morning. So I will go ahead and direct some questions to our panelists, and you're welcome to type more in the Q&A box if you think of more. The first question, I think Dr. Osborne may have answered in the question and A box, but we'll address it here for the whole group. So what are the other possible conditions when you have very similar vision loss in both eyes as shown in the visual field test? So besides NMOSD.
Great question. So by far the most common optic nerve problem is glaucoma, which is not something generally a neurologist would treat. So that's something that can easily get screened for or diagnosed by a general ophthalmologist. And then there could be other forms of optic nerve damage from, again, multiple sclerosis. I very briefly alluded to MOG or MOGAD, which is something maybe I'll talk about next year. And then sometimes patients can get something called ischemic optic neuropathy, where they can just have a blood flow problem, kind of like a small stroke to the optic nerve that can also cause problems like that.
Thank you, Dr. Osborne. Next question is for David. It's a very practical question. Why are clinical trials words always in capital letters? Where do these names come from? For example, the trial Enlighten.
It's a great question. So the names come from, they're assigned by the sponsor. So usually a pharmaceutical company that is sponsoring the trial or funding it. And each study has a unique short name used as an identifier or reference that we just reference it as colloquially.
Thanks so much, David. Dr. Brio, there was a question put in the chat earlier. Can you be tested for Epstein-Barr virus?
So the answer is yes, you can. I think the issue with the testing is what would it mean? Because the truth is, like I said, about 95% of the US population in general has been exposed to the Epstein-Barr virus before. So, you know, just being tested for it might not really tell us much down the line, but you can be tested for it. The other thing too about it is that just being tested for it, there's a way to tell if it's an active infection or not, but just most of the testing when it comes back, it just tells you, okay, you've been exposed to it at some point in life, but that can't tell you really when. So yes, I guess the short answer is you can be tested for it, but it kind of depends on like how we can use this data moving forward to help with care.
Excellent, thank you. And Dr. Safadi, there was a question from a patient, again, about the new bivalent COVID-19 vaccine, and it was specifically for patients on Gilenya. You know, would this be recommended for patients taking Gilenya? Would that be any different from other disease-modifying therapies?
Yeah, no, that's a great question. We recommend the bivalent COVID booster for everyone, regardless of what disease-modifying therapy they are on, including Gilenya. Yes.
Okay, thanks for that. Dr. Manrique, there was a comment/question from a patient in the Q&A box. They said they had to go to over 6 different neurologists over 25 years before someone finally correctly diagnosed them with multiple sclerosis. Could Latinx patients be less likely to receive an MS diagnosis because they are less likely to be persistent in their search for diagnosis and treatment? So I don't think there's a black and white answer here, but maybe this is something we need to look into further. But any thoughts on why this patient or others may have struggled with that?
Yeah, that's actually a very good question, because that reflects an issue with access to healthcare system and actually to the diagnosis as well, delaying the diagnosis. And I feel like if we think about it, probably underserved populations or minorities are more exposed to that. And it's not because they are less persistent, but oftentimes all of these barriers makes things even more difficult. So they might get burned out and tired easier. And actually, and then in the other hand, there are some sociocultural and some emotional component to that can affect how likely they are to keep seeking care. So that's the kind of situations that we're trying to address with our project and perceptions of illnesses, and see how their diagnostic process have been going on, and see what are those potential barriers and how they face them. So that's a good question.
Thank you. There was another question in here that I think maybe Dr. Osborne could answer. Someone's asking, how would you find a doctor who deals with low vision loss?
Great question. So there are some low vision clinics in the DC metropolitan area. So you could actually just search on the internet. The low vision specialist can do a full exam, and then they can recommend sometimes assistive devices to help patients with low vision that can't get fixed with just regular prescription eyeglasses or contact lenses. If you just type in into any internet search engine, low vision eye specialist, you'll find somebody close to where you live.
Thank you, Dr. Osborne. There is a question here, Dr. Amjad. It's about discussing spasticity, which is, I know you've given that actually as a lecture in previous years, and they're interested in activities in spasticity. Maybe this is a conversation between them and their provider, but maybe give them a good place to start.
I'm sorry, Bethany, what was the exact question?
Just discussing spasticity and what resources and activities are out there. That's a very lengthy conversation, but maybe just a little starter tip.
In general, first you need to get evaluated by someone, by a neurologist or another physician. But spasticity, very simply put, is a sensation of tightness, stiffness, and that can manifest in many different ways. It could be spasms, it could be severe muscle cramping, it could be even if you don't feel stiff necessarily to the provider, when you start walking, the stiffness may come out. So I think a good evaluation, a good history is the first place. And then from there, we can do interventions in terms of medications or physical therapy, or something that's a little bit more targeted or focused, like botulinum toxin. So I think the first thing is trying to maybe find a healthcare provider to speak to about it.
Yeah, thank you very much. David, there is a patient who is asking for those of us taking Ocrevus as our first disease modifying therapy, could our data be used in the Treat MS trial, or are we not eligible?
It's a great question. So unfortunately, previous treatment, anyone who has received previous treatment with Ocrevus, that would be exclusionary for this study, because they're looking to initiate and randomize a certain rate upon entering the study. So yeah, unfortunately that they wouldn't be eligible, but thank you for the question.
Yes, and thank you for your interest in our clinical trials and for asking more, and hopefully we appreciate everyone who participates. There is a question here about, do we recommend pain management doctors? I would again say, similar to Dr. Amjad's answer, that I would start that discussion with your provider and sort of figure out what kind of pain this is, and then where to go from there. Because there are different resources out there, like our friends in physical medicine and rehabilitation and such. Does anybody else have any comments about pain management on the panel? Okay, then let me give this, I'm going to check the chat box, and I'm going to give this a few more minutes for everybody to answer any questions.
I do have a question for Victoria. What do you think are the in your experience, what do you think are the potential benefits of being part of initiatives or communities like We Are Ill? How do you think that has benefited the individuals that have been with you, and how does that change their perceptions of illness and the way that they interact with providers?
Great question. It's layered. So the first layer is it took me about 4 years to meet another Black person with MS in person. So, seeing yourself and knowing you're not this, one-off, I think it just changes your perspective on it. You feel not so isolated. So that's the first thing, having community. And then secondly, our main goal to redefine what sick looks like is that sickness it doesn't mean sad. It doesn't mean it's the end of your life. It doesn't mean that you can't enjoy life or live a full life on your own terms. So it's given a lot of people confidence and community and connection, and just a refresher on how we're going to navigate this thing with confidence and self-respect. And then as far as connecting with the healthcare community as a whole, so healthcare providers and navigating insurance and everything else, I think it's given everyone a battery in their back. So again, more confidence, and really giving them the tools and resources to say, okay, these are my rights as a patient, or, I want a second opinion. Giving them the confidence and the language, because health literacy is a thing as well, but giving them the language to articulate their needs or their demands, or, asking more questions. So it's been a full circle package of good things. And last week in person, we really were, I want to say, validated in that the work that we're doing matters, because we were able to hear it in real time, see it in real time. And all of the ladies felt like they left with information that resonated with them because it was coming from someone that looked like them. So full circle, good things all around. It's definitely beneficial.
Thank you. I think that's amazing. In Hispanic and Latinx individuals, they really do have different difficulties finding community and finding people that look like them. So and then the point about health illiteracy is also like very relevant, because the way that they can see that this is different is like finding other people that tell stories and like learning about it in a practical way. I feel it's more resonant than just like reading on the web whatever they say. So I appreciate that. Thanks.
Thank you.
Thank you. There's one more question here. And maybe Dr. Tornatore, if you're still here, I'll have you address the question. It's saying that these are pretty broad, drawing on expertise. Do we see a higher incidence of more mechanical spine issues like degenerative disc disease or stenosis in MS patients? And also, do you have any insight on the neuroprotective benefits of SSRIs?
So with regard to disease of the spine, there's no question that we see more disease of the spine, both in the neck and the low back, as well as in the mid back, so cervical, thoracic, and lumbar. Mainly, and it's not all MS patients, but it's predominantly because patients have spasticity, they may be wheelchair bound, they may be using assistive devices, all of which may throw the biodynamics of the spine kind of out of whack, if you will. And so very commonly, we will see patients that have neck or back pain, not necessarily due to their MS, but as a result of having some type of weakness that then puts them at greater risk for having biodynamic stress on their spine. It kind of goes back to the question, when do we refer folks that have pain to pain specialists? And I thought the answer was terrific. It really depends on what the nature of that pain is. If it really is neck, back, or mid-back pain, then there are things that we can do to help with it. Physical therapy can help, physiatry can help. Sometimes local blocks can be helpful. And in the worst case scenario, if the spine, the vertebral bodies, and the discs are so injured, then perhaps surgery, although we really try to avoid surgery at all costs. So there's no question that spine is a big issue for our patients. This is why we have seating clinics. If somebody is in a wheelchair, we make sure that the wheelchair that they're sitting in has been appropriately tailored to their needs. So really, really very important. And in truth, our whole goal as an MS center is to keep people walking, right? If we keep people walking and ambulatory, then the spine issues become a non-issue. And a lot of that rests on just, great patient care, the therapeutics that we have. Again, thank you to all the sponsors. But there's no question that where we are now is much, much different than where we were even 20 years ago. And so we see less and less spine disease, but it's still there. The second point about SSRIs and neuroprotection. So neuroprotection is a super interesting area because it really is dealing with how do we keep the nervous system from getting injured, or for lack of a better word, how do we keep it from aging excessively? And could an SSRI, or for that matter, any other drug, be neuroprotective in some way? I think there is no question that we are going to find neuroprotective medications, and they already exist. We know that there are certain things that clearly have a benefit to the nervous system and protect it from being injured. Those include simple supplements, things like vitamin D, B12 supplementation, omega-3 fatty acids, exercise, not smoking. They all sound pretty simple, but there's no question that those are all neuroprotective in their own right. SSRI, serotonin, selective serotonin reuptake inhibitors are antidepressants. And there is some data to suggest that if you are on an SSRI, that perhaps there is greater longevity. Now, this is confounded by the fact that we're using those to treat people with depression. And people who are depressed have a higher incidence of suicide. And so by treating depression, there are fewer people that commit suicide, and therefore it looks like they may be living longer. So it's not clear that they are neuroprotective. I think there are great studies that could be done to look at, okay, if you're on an SSRI or any other drug, is your MS disability slower over time relative to your peers? And so there is a lot of work in this area. It's a great, great question. Love the concept of neuroprotection and neuroregeneration, which maybe this is a great closing comment, we will definitely address at our next patient education event next year. I think remyelination, repair of the nervous system, protecting the nervous system, all of these are really the holy grail for what we are all trying to do in the clinic and for most of our patients, to be quite honest. I get that question every single day from somebody. So, when's the cure coming out, Dr. T? When are we going to get the repair drugs? And I always kind of sheepishly scratch my head and say, well, it's around the corner. But I really believe that it is getting closer. So kind of a long-winded answer to the question, which is great. One more practical than the other. I'll stop there.
That was great. Thank you. So I think we maybe have time for another question here. And I think this is timely, and if anyone wants to take this, that would be great. But it's regarding, patients who, being basically many patients have been switched to generic. And if there's any thoughts on, when that happens, some patients go on to Medicare or other insurances and then have to go to generic, and what's the best way to approach and how to navigate changing insurances and just making sure you talk to your provider.
That's a really great question, extremely practical. The bottom line is we need a new healthcare system. This is so broken, it's ridiculous. The fact that, you could have one healthcare, whether it's commercial, then go on to government, and then all of a sudden you are in a different pool, that your insurer may decide that you need to be on a generic. And there's only one reason they do that. It's cost. That's plain and simple. And so it's a broken system. It's terrible. Somebody who's been stable for years, they're on their medication, and then they're told, oh, guess what? You now need to be on a generic, which may or may not have bioequivalency. Or we're not going to cover this medication at all, or this class, and you need to be switched off. It's terrible. It's a broken system. It's got to go. I can tell you that everyone in our MS center works extremely hard to push back when somebody gets a letter of denial from an insurance company. As chair of the department, I have hired 7 people whose only job is to fight with insurance companies and to do prior authorization. That's unbelievable. That's their whole job. 7 full-time employees that fight with the insurance companies, including we have an 8th person actually that helps with the prior authorization also. So it's an enormous amount of work that we put into this issue. And as Bill Clinton used to say, I feel your pain. We are with you every day. We deal with this nonsense, and it is absolute nonsense. And I think there are times when we fight the good fight and we just can't win, and so then we try to do the best we can and find the right alternative for medication. Sometimes the generic is our only choice, and that's what we go with. Sometimes cost is so prohibitive that we have to go with the generic because otherwise the cost is so prohibitive for a patient. But the bottom line is it's a broken system. We've got to do better than this. And I think there are smart people that are thinking long and deep about this. But I think all of us have to be at the table and be very, very vocal when it comes time to elect our officials, when it comes to holding insurance companies, holding their feet to the fire. All of this has to be something that all of us do and be very, very vocal about. So I don't have an easy answer, but I can tell you that we have the infrastructure to help fight for you if you're part of our center.
Yes, and just to echo what Dr. Tornatore said, thank you to Dr. Tornatore, and a shout out to all of the many people in our department who really make things happen. So they're really wonderful, and we could not do it without them. Everyone, I think it's that time where we're going to end this morning. Thank you for spending it with us on behalf of everyone at the MS Center.
Before we stop, Bethany, I really want to give a shout out to Bethany, who really did 95% of the work organizing this. It's an enormous amount of work. Getting the IT, the logistics, the speakers, which is like herding cats, to get their slides, to get everybody together, sending out emails to patients, getting the sponsors, all of it. An enormous amount of work. And I don't think I have one time ever heard Bethany complain, ever. And so you deserve an enormous amount of work. Usually we do this in person, we give you flowers, that's totally inadequate. And now even just this is even less adequate. But we really wanted to recognize you for this. So we love you. It's just great.
Thank you, Dr. Tornatore. It is a pleasure. I hope that this morning event is meaningful to everybody. I know that I look forward to it and appreciate hearing the lectures. And don't forget to fill out your evaluations. They should be emailed out to you. So look for those in your inbox. We do look at those. We try and pick talks that are tailored to what you guys, what patients, what's relevant to them and what they would like to hear. And so the evaluation forms are one. This site, save this website. This site will remain up for 6 months. So in about 2 weeks, I think we'll probably have a recorded version of this presentation up. And also, please come back and visit the sponsor pages. A big thank you again to our wonderful sponsors who helped make today possible. Thank you to all of our wonderful panelists who took time to share with us this morning. We really appreciate your ideas and thoughts. And most of all, thank you for joining us. We hope to see you maybe in person next year.
Yes.
That would be the best treat of all, wouldn't it?
Absolutely.
It would be wonderful. And enjoy the rest of your day. And if you have further questions, please email or reach out to your providers directly so that we can, help in any way we can. So thank you.